Today we will have four scenario for clinical consultation. So, can everyone hear my voice? I hope it's
Yeah,
clear.
can.
Okay, yeah. All right. So, just to recap a bit on the format. So we know that we got two clinical consultation scenario in the exam. So you are all the candidates are given 5 minutes to prepare, and then we expected to actually crowd the patient about 8 to 9 minutes. I think at max also 9 minutes, and then try to spend a bit more time to examine the patient at 4 minutes. For total of 3 to 4 minutes if possible, and then when the examiner give a reminder of last 2 minutes, then only we ask about concern. And then following after is 5 minutes of viva. Okay, so we will start with the first candidate, Dr. Ben, right? Are you there?
Yeah, I'm here.
Okay, so you are ready?
Yeah.
So we will give you, as usual, our ground rules here is always 4 minutes instead of 5 minutes. Okay, so I will give you 4 minutes to prepare this scenario. I will start the timer now. Okay, time's out. This is the patient, Mr. Paul. You can start now, Dr. Ben.
Hi, Mr.
Okay,
Paul.
so
Good afternoon. I'm Dr. Chia, one of the doctors in this clinic today. May I know what's the name, please?
yeah, it's a Mr. Paul.
All right. I received a letter from your doctor actually stating that you have an abnormal blood result. But before sitting on that, is it okay if I ask you a bit questions regarding your general condition?
Yeah, sure, sure.
All right. How have you been feeling lately, Mr. Paul?
Great. I don't have any issue.
All right. I'm going to ask you a few questions that may or may not be relevant. Hopefully you can answer me.
Okay.
Recently, do you feel tired easily?
Yeah, I do feel tired for almost 6 months now.
Already 6 months. Huh? All right. Has it 6 months before this, were you perfectly well?
I don't feel anything unusual. However, when you mentioned about this, I think about 6 months before this, I already feel a bit easily tired. I don't
I
know
see.
why, doctor.
That must be very worrying. May I know, has it been actually progressively become more tired? You get tired more easily?
I think it has been quite the same.
Okay, sure. Anything that you feel that this tiredness actually being more worse over the days?
No, I mean in the morning and night it has been the same as well.
All right. Do you feel fresh after your sleep?
No,
All right. Do you feel that this tiredness actually helped by sleeping or resting?
no.
All right. How's your sleep quality, Mr. Paul?
I think I have no issue in sleep.
All right. Sure. Uh, Otherwise, besides the tiredness, do you have any other symptoms that you have been feeling over the past 6 months?
I do have some headache. I think about 3 months. It occurs on and off, and it's like when I feel a bit stressed, I will get headache easily as well.
All right. And can you tell me more about the headache? Usually, where is the headache?
It's at the both side of my front part of my head.
Stress?
Yeah.
Do you take any medication to try to relieve the pain?
No. It,
All
it's
right.
actually quite mild. Sometimes even if I feel the headache, I try to rest and then I will feel better.
All right. When you're having the headache, do you feel any changes over your vision
No,
or any changes over your hearing
no,
or any abnormal movement of your hands or legs?
no,
All right, sure. Um, do you have any fever?
no.
All right. Do you feel you're sweating at night?
Not really.
Not really. Do you have any weather preferences by any chance?
I don't feel anything unusual with hot or cold weather.
Sure. Do you feel any unusual lumps and bumps over your body?
No.
Have you ever noticed that you bleed easily?
Bleed easily as in I have like bruises or bleeding.
All right.
No,
All right. Have you noticed any nose bleeding or
no,
gum bleeding? Not really, yeah. All
no,
right. Do you have any joint pain,
no,
any muscle or bone pain?
no.
All right. Um, may I know how's your appetite recently?
My appetite is good. I don't feel anything unusual.
All right. Any changes over your weight?
No.
All right. How's your diet? Do you take like just a normal adult diet?
Yeah. I don't restrict any form of diet.
Are you taking both meat and vegetables?
No. Yeah. I do take vegetables and meat both.
All right. Sure, no problem. Um, do you have any pain on your tummy?
No.
Do you see any changes over your waterworks?
No.
Any blood inside which you notice in your waterworks?
No.
Okay. How is your bowel opening?
It has been regular. I don't see any changes.
Do you have any difficulty passing motion by any chance?
No.
Or notice any blood in your stool?
No.
All right. Do you feel breathless usually?
Breathless, as in, yeah, I do feel a bit of breathless if I walk a long distance.
All right. Other than that, can you still lie flat to sleep?
Yeah, I can.
All right, sure. On the other hand, do you feel easily get dizzy?
Easy. Sometimes if I change position, like suddenly, that I may feel that, but usually no.
Has it been happen more often than usual?
Mm, on and off, I would say it's not getting worse.
It's not getting worse. All right, sure. Uh, may I know, do you have any medical condition previously?
Yeah, I do have a headache for quite some time, doctor. When
All right,
it was like almost 2 to 3 years now, and then I went to seek multiple GP. They told me it's more to migraine headache, and I also do have accident about 1 year ago. I have a car accident when I was got hit by a motorcycle when I was driving a car, and then I got admitted and then got bleeding doctor told me I got bleeding in my spleen, this organ, and then I have to underwent emergency surgery to stop the bleeding. So the doctor told me that my spleen have to remove. So since then I was on the antibiotic for lifelong. It's called penicillin.
I see. There must be this very unfortunate. Um, have you been taking the antibiotic regularly?
Yeah, yeah.
Are you still seeing doctors for this medical condition?
No, no, no. I mean the surgery was like 1 year ago. I'm already well.
All right. Are you still, but you are still taking the antibiotics?
Yes, yes.
All right, sure. Besides the antibiotics which you mentioned to me, any other medication you are taking?
No, like I said, I seldom take any painkillers at all. It
All right,
usually, it usually will resolve, and I don't really take anything else.
all right. Are you taking any traditional medication?
No,
All right. Sorry to ask, this might be a bit sensitive. I hope that you don't mind. May I know, do you smoke?
no, I don't. I don't.
Okay. Do you take any alcoholic
No,
drinks?
no,
Okay. By any chance that did you use any recreational drugs?
no.
All right, sure. Um, Besides that, are there any medical conditions that runs in your family?
Not that I'm aware actually. All my family members was well.
All right, sure. Any problem with blood is inside in your runs in your family? Any illness with blood that you know of?
You mean blood problem?
Blood,
No, no,
yeah, blood related illnesses
no, no.
which you know of. No. All right, sure. May I know what do you work as?
I work as a yeah. I work as a uh. I used to work in the car garage as a foreman, but now I already retired after the surgery.
All right. Did this tiredness and all actually affecting your life?
Yeah, yeah, it has affected me on and off, and then I feel, like I say, I feel I'm not as strong as before.
All right. I can see that you're pretty concerned with this. Hopefully by the end of this consultation, I can get to the bottom of this. Is it all right that if I examine you, Mr. Paul?
Oh, sure, sure. Come.
All right. I will start from the peripherals. Is there is the patient caucasic?
No, the patient is not caucasic, but you can see if you start from the hand looks like this.
All right. Are there any petechiae also over the hands? No.
No peticate,
All right. Can I look for any clubbing?
no clubbing.
Okay. I would like to feel for the pulse in a pulse rate.
The pulse volume is good. The pulse rate, doctor, as Amir told you, is 70 beats per minute.
All right. I will move to the patient's head. Check on the eye. Is it pale or jaundice?
No, no. Perhaps there's a mild pallor, but there's no jaundice.
All right. I will just look into the mouth. Any abnormality or ulcers?
No.
All right. Um, Check for cervical lymph nodes.
Okay, as you feel the neck from the right side, then followed by the left side, and slowly feel you can't really feel any obvious lymph nodes.
All right. I will listen to the heart to look for any signs of heart failure.
Okay. the heart, you just want to auscultate, right?
Yeah,
Okay, as you auscultate, you can hear S1 and S2. There's no added murmurs, or there's no S3.
any biphasic crepitations.
Okay, when you examine the lung, there's no crepitation heard.
Okay, I will proceed to the abdomen.
So this is abdomen.
Okay, uh, just feel for any hepatomegaly.
Yeah, when you lie down the patient, and then when you sit, and then you try to palpate, you feel that there seems to have a hepatomegaly.
All right, I would like to percuss on the chop space also.
Throat space, when you want to percuss it, doesn't really have any, is resonant.
All right, I would like to look for ascites as well.
Okay, you perform shifting downers, and then 10 seconds later, is still resonant.
All right, I would also like to ask for permission to check for the inguinal lymph node.
Okay, examiners say you can skip that, it's negative.
All right, Mr. Paul, there are a few more questions I would like to ask.
Mm-hmm.
Hello.
Yeah, hello, yes.
Yeah, hi, Mr. Paul, did you receive any vaccination?
Yeah, I have received all the vaccination in the past.
Particularly, did you get any meningococcal or streptococcal or pneumococcal vaccination, if you have heard these terms before?
Yeah, I have received influenza, COVID, pneumococcal, and also the meningococcal as well.
All right, great to hear that. So, may I know what's your concern, Mr. Paul?
Yeah, doctor. So what am I having, doctor?
All right, Mr. Paul, I think at the moment, the condition you are having is likely to be
2 minutes left.
related to the operation of the spleen, which has done earlier on you. It can also explain why that you are having this headache, because one of the blood cell, it's called the platelet, is on the high side. And at the same time, you are feeling tired. And I think that this is due to because of your red cell is also on the low side at the moment.
Okay. Then what is the next step for me, doctor?
Um, I'm going to take a few blood tests for you, Mr. Paul, which I will further discuss with one of the blood doctors, and we will start some treatment for you to bring down the platelet level. Does this sound all right
Oh,
to you?
what is the treatment, doctor?
It's actually one type of medication which target to the platelet actually.
Oh, okay.
Yeah.
Then, but do I need to be admitted?
I think at the moment we can still monitor you as outpatient. Um, we will see you back in the nearest clinic date together with all the investigations taken today. Does it sound all right to you?
Okay. Then, doctor, is this condition reversible?
At this point of time, I do not have enough information to disclose the answer to you. But as the time comes by, where all the investigation results come back, then we can have the discussion further along with our hematologist, our blood disorders doctor.
Yeah, doctor. My main concern is actually because of this weakness and also issue in my blood. Can this be some form of blood cancer?
Okay, that actually also at the back of my mind. So one of the blood investigation I'm taking today is actually to look into your blood cell to see if there are any abnormal blood running in your blood. Um, After that, if we have high suspicion on that, we might proceed for a further investigation also.
So it's possible, doctor, is it?
I'm afraid that that is still possible.
Okay. All right. Sure. Okay, time's up. 5 minutes. So, Dr. Ben, what is your working diagnosis for this patient?
I think that this patient is having a thrombocytosis slightly secondary to previous splenectomy.
Mm-hmm.
My differential diagnosis would include essential thrombocytosis as well as myeloproliferative disorders.
Okay. What is your clue towards this as a primary diagnosis of post splenectomy thrombocytosis?
As patient had a splenectomy done earlier, and he's not on any antiplatelets at the moment or any hydroxychloroquine being prescribed to the patient. Oh, sorry, hydroxyurea being prescribed to the patient.
Okay. Another thing is that what is the supporting features for you to suggest that this may be due to myeloproliferative disorder, particularly essential thrombocytosis?
As a patient is having hepatomegaly, there might be a cause of essential thrombocytosis due to the extrapoietic hematopoiesis.
Okay. Is there any other differential?
The other differential would be other myeloproliferative disorder, and
Mm-hmm. Which you already
I will,
mentioned.
yeah, which I would also like to consider multiple myeloma as one of the differential diagnosis.
Okay, but what are the features to suggest multiple myeloma?
At this point of time, there is only anemia. Patient do not have any bone pain also. Yeah.
Do you ask about any kidney symptoms at all?
I did ask about the urine, but I did not ask about the volume specifically.
Okay. So are any other differential?
That's all I can think of at the moment.
Okay. Is the patient anemic to you?
Yes, the patient is anemic.
In regards to that, is there any differential diagnosis you can add on?
I would also like to rule out the other solid organ malignancy. However, the patient does not have any changes in bowel habits to suggest of that at this point of time.
Okay. How will you work out this patient in terms of investigation?
This patient can be worked out as an outpatient. I would like to take a peripheral blood film along with a repeated full blood count to confirm the diagnosis. To confirm the finding.
So
At the
what,
same
what, what do
time,
you expect? What do you expect to find in the peripheral blood film?
it will be an essential. It will be a high platelet in the microscopic field, a high platelet count in the microscopic field, and also I would like to look for any abnormal red cell presentation, and at the same time, the red cell morphology can also help us to point towards any causes of it, and also I would like to look for blast as well in terms of myeloproliferative disorder.
Okay. Other than that,
Renal profile would be important in terms of picking up an acute kidney injury, especially if also having hepatomegaly. I would like to look into the liver function test to look for any raise in transaminases. At the same time, I would like to send for an effective screening, which include the hepatitis B, C, as well as HIV. To look for any viral infection that can cause similar presentation in this patient. Subsequently, I would like to request for an ultrasound abdomen to study the aqueous texture of the liver, and also specifically to confirm there's splenic patient. And subsequently, I think if the previous results are unremarkable or needed to further investigate, the bone marrow X-ray and the trophine biopsy would be important also in this patient, along with a CT thorax, abdomen, and pelvis.
is there any parameters that you will order? Let's say you can order send it to the peripheral blood or you want to send it to the marrow blood. But is there any test that you can order, let's say, to exclude or confirm myeloproliferative disorders?
I think over the peripheral blood, immunophenotyping can help. And for myeloma per se, urine protein erythropoiesis can actually help in diagnosing that.
Okay. Okay. So how will you manage this patient based on your most likely diagnosis?
At this point of time, I think this patient can be started on hydroxyurea, which can help with the platelet count. And subsequently, he should be referred to a hematologist for further evaluation along with a specific treatment after reviewing all the investigation.
Okay, time's
Patient
up. Okay, but do you just an extra question? Do you think the patient need to be started on blood thinners, antiplatelet?
at this point of time, I think no. But
Okay, but
antiplatelet, I think aspirin may be helpful in this patient.
okay, all right, okay. So, Dr. Ben, how would you think about your performance?
I think to begin with, this patient did not come in with a chief complaint, but abnormal blood result to begin with. So the
Mm,
approach will be slightly different
mm,
compared to a patient with a chief complaint. I think I would need to think more about the differential diagnosis. I forgot about the iron deficiency part.
which can cause
Um,
fatty thrombocytosis, right?
yeah,
Mm. So my question to you is when you encounter this scenario as you prepare, what are the differential diagnosis you got?
um, it's more towards the hematological pathology.
Mm-hmm.
Yeah, as what I mentioned to you earlier just now,
Yeah, but then other than that,
and infection.
okay, good. Other than infection, you mentioned malignancy, infection, any other thing
I think that is all at the moment.
when you prepare, right?
Yeah,
How about chronic inflammation?
yeah. I think I did not. That did not cross my mind actually just now.
Hmm. Okay.
All right.
So yeah, a few questions for you. Between post-splenectomy thrombocytosis versus the myeloproliferative disorder, why you choose post-splenectomy instead of myeloproliferative disorders? Because these two are the
Mm,
possibility, right?
yeah, I think the because of the white cell line is actually still quite normal. The counts are not too abnormal per se. That's why I choose towards.
Well,
Uh,
but we don't in exam we don't really look at counts per se to decide the diagnosis, right?
yeah.
Hmm. I mean, I can argue with you that there is anemia also. There is like a possibility
Mm,
that involve two lineage. One is high, one is low, one is like normal. But we don't look at the result to really decide on the differential which one is the most likely diagnosis. Right? Because if you commit the primary diagnosis wrongly, unfortunately your management that part will be penalized. Although your discussion part may not you may still get 1 mark like that, but definitely not 2 marks. So you need to really work smart on this, and then you try to see whether examiner want to hint you to which one. Have you encountered any patient with post-splenectomy?
yeah.
Hmm. And do you realize their pellet counts?
I usually normal actually.
Oh, normal. So how long
Yeah.
it takes for surgery, after the surgery, the pellet should normalize? Do you know
I
how
think
long?
within 3 to 6 months will be normal already.
That's too long. So usually by post-mastectomy, the pellet should normalize by 3 to 4 weeks. Okay, and most also up to 6 weeks. It should normalize completely. If it does not normalize, then you really need to exclude myeloproliferative disorders. So particularly in this patient, the splenectomy was done like 1 year ago, right?
Yeah.
So does it make the diagnosis less likely?
And yeah,
Yeah. So if you think along this line, then perhaps you will not sell the post-mastectomy thrombocytosis as your first diagnosis lah. Oh.
correct. Yeah.
But if you think this is myeloproliferative disorder like essential thrombocytosis, right? What are the symptoms? I can see that from the history you try to elicit some hyperviscosity symptom. Immediately after I tell you I got headache, you ask about blurring of vision, you ask about a lot of the other things, for example, any hearing issue, a lot of things that is a bit subtle, but I can see that you try to exclude some hyperviscosity syndrome. But do you have any idea that any other symptom that may be important that to point towards myeloproliferative disorders?
If it's PCV, then the patient will flush after the shower, something like that.
Patient will not flush, but patient will feel itchy.
Itchy,
Okay.
yeah.
Aquagenic pruritus is one of the strong symptoms to suggest MPN, regardless of PCV, regardless of ET, no? So they tend to get itchiness, especially a hot shower. So this is very important too. If you manage to get this symptom right, then you won't talk about post-splenectomy thrombocytosis. No? At the same time, look at the patient hand. What do you find in the patient hand?
To be honest, I can't see anything.
But look at the distal fingers. Do you think it's slightly more redness compared to
Yeah,
the proximal?
yeah.
Yeah. So this is actually erythromelalgia, which is the distal redness, distal vasodilation of the vessel. No, it's erythromelalgia. And if you get the aquagenic pruritus, erythromelalgia, and in this kind of patient, you should really look hard for the conjunctiva, want to look for any suffusion, okay? Because of the hyperviscosity, patient may develop some form of conjunctiva suffusion, just like a chronic CO2 retention patient, like those COPD patient, when they come in exacerbation, you will see that their eyes, the sclera will tend to be congested with a lot of small capillaries. So all these are point towards hyperviscosity, and then in particularly primary marrow disorder. My question to you is, in post-penectomy thrombocytosis, do you give hydroxyurea?
Actually, we don't.
So we don't. Actually, the answer is no. No, it's really no. We don't treat reactive thrombocytosis with cytoreductive therapy. Oh, we never do that. Okay, because we only give cytoreductive therapy in patient with primary marrow disorders. Okay, primary, which means the myeloproliferative disorder lah. Okay, so we don't give the cytoreductive agent at all. Okay, another thing is that when you ask about the question regarding the role of antipellet, you say might be useful, right? So will you give or not give? Let's say you know that this is a MPN, like a ET.
ET, I think hydroxyurea,
Mm-hmm.
aspirin, if I'm not mistaken. Actually, I forgot. I have no idea.
But this is important, is the knowledge part. Generally, we need to give antipellet. We need to give single antipellet. Usually, it's aspirin. But there is some caveat to it. I will talk about it later. Why we need to give is to reduce the risk of having a stroke or even any risk of thrombosis. So anyone have age of more than 50 years old or have a previous history of thrombosis, if you ask me, right, this patient actually have a mild uh, a mild stroke in the past, but I did not voluntarily offer it until you ask lah. So it's actually kind of like a trick question, because this patient actually you want to assess the thrombosis risk. Any patient with high pellet or high HB, you need to really assess for thrombosis risk. You should ask a very specific question, whether there's any clot in your leg previously. Do you have any history of heart attack, for example, or any chest discomfort? Do you have any stroke or mini stroke in the past? You need to ask a very specific question, okay? Because we know that patient with MPN, right, regardless of PCV or ET, generally they are actually at risk to develop thrombosis. So that's why most of the patient should be started on antipellet, as well as CVS risk reduction strategy, including statin, including exercise, weight loss, stop smoking if patients smoke. Okay, so all those things should be there. Another thing is the cytoreductive, let's say this is a primary lah. So I just want to I will discuss further, don't worry, but just want to go through your marking scheme lah. I think your clinical communication skill is okay, but your physical examination, okay, I would say fine, because you managed to get the idea, but the erythromelalgia is something you should mention, in which you cannot appreciate. But perhaps you get 1 mark instead of 2 marks. If the examiner is going to calibrate, is perhaps you're going to calibrate the scar, the hepatomegaly, and also the erythromelalgia. Okay, I mean that are the hard sign. The rest of it, important negative is the no limb adenopathy, for example. Clinical judgment, unfortunately, you only get borderline, although you get your differential diagnosis as myeloproliferative disorders. Concern, I think you address most of it. I think it's fine. Are there any physical sign? That one, yes, like I mentioned to you, the erythromelalgia part, 1 marks. Differential diagnosis, unfortunately, I would give you only 1 mark as well, although you got the 2 main differential, because you really need to expand your differential diagnosis. Cannot just give 2 differential as only, not enough. You must write more than that, like for example 3 to 4, or even like 5 differentials. But I think well 5 you get most of the marks. So generally, if you go for this station, right, so you may get about half of the marks, okay, for 2 examiners. So it is not enough. In exam, we need to aim for at least full marks. Okay, we can only make a very minor mistake. That's why it's important for you to really, when you are start with a differential, which one to go, you should really go to which one is the most likely. okay, and you listen to what the examiner try to hint you, okay. Sometimes the examiner might, like me, I may not hint you, okay. Some examiner, they will just let you proceed, they will not question or they will not ask you back anything. So if you read, I mean, this is just some important points that you mentioned in the history as well as the marking scheme lah. So this one I actually fast forward to become 1 year lah, just to test, because I think 10 years, definitely if I tell you 10 years, you know that this is less likely, but just want to test your knowledge whether post-myectomy 1 year is still possible to have thrombocytosis. Okay, so I fast forward a bit, and then this one is a history of minor stroke, which I didn't mention because I really want to particularly want you to ask about the risk of thrombosis. And then erythromelalgia, hepatomegaly. If you got time, because of headache, you may want to do a quick pointer screening, but I think it's like soft sign, not important. The important thing is to really tell the examiner that I think this can be due to primary or reactive thrombocytosis. Primary is due to this essential thrombocytosis or MPM. Reactive can be due to all this. No? So hemolysis or acute blood loss is also one of the possibility that can cause reactive thrombocytosis, other than IDA, inflammation, infection, and trauma is also important. Okay, so investigation, PBF is actually not to look at blast per se, because if let's say you got blast in the PBF, the diagnosis is no longer myeloproliferative neoplasm. The diagnosis is myelodysplastic syndrome. Okay, it can be myelodysplastic syndrome with excess blast, myelodysplastic syndrome with adequate less blast, things like that. But it definitely not MPM alone, huh? So if you mention the indication for BBS, it's not just about looking at the blast, looking at the abnormal red cell, and then actually if I'm you, I will tell like that to make it simple. Right? I will tell the examiner that I will order a peripheral blood film to confirm this is a true thrombocytosis. I will expect may find a lot of megakaryocytes. Other than that, I will also want to look for any leukoerythroblastic picture that may suggest myocardial disorders. Blast I will not mention because I'm not thinking towards MDS at the moment. It is possible, but I don't want to mention about that. Okay, mutational study is something that I want you to mention, but you didn't really mention. You mentioned about immunophenotyping, everything. Because this mutation study, even if patient did not go for marrow, like let's say the peripheral blood positive for JAK2, or for example positive for calreticulin or myeloproliferative protein, that is already considered as primary, is confirmed. Okay, even without marrow. That's why it's important for you to mention. And then bone marrow, the main indication for bone marrow, other than confirming this is a MPM ET, is actually to differentiate the reason why we do bone marrow in essential thrombocytosis or primary thrombocytosis is actually to differentiate MPM versus prefibrotic myelofibrosis. Because in prefibrotic myelofibrosis will also present similarly like essential thrombocytosis. And the only way to differentiate, not by symptom, but by looking at the marrow to look for the fibrosis. So that's why it's important. Okay, and also usually they will have some atypical megakaryocyte as well as compared to normal megakaryocyte looking. And then this is another thing that I want to highlight as well. That's why I want to test whether or not you will start the patient antipellet. In patient with thrombocytosis or even polycythemia, yes, we should start antipellet. We should reduce the risk of thrombosis. But anyone with a pellet more than 1,000, regardless of essential or primary, regardless of essential or reactive, we should not start antipellet. Because as the pellet more than 1,000, if anyone got watched the recording regarding the bleeding disorder, the patient will be predisposed to acquire von Willebrand syndrome. And patient actually have a higher risk of bleeding than higher risk of thrombosis if the pellet is more than 1,000. So that's why it's important. And if you think of this aspect, you may want to impress examiner by saying that I will also send the von Willebrand screening as well, because as pellet more than 1,000, they may also have a risk of acquired von Willebrand syndrome. Okay, but that's not important. This is something just additional. Management-wise, MDT, hematoreferral, cytoreductive agent, because you're thinking this is essential. So you want to consider cytoreductive agent. Commonly, you can start hydroxyurea or anagrelide or PEG interferon, depending on the patient risk profile. Okay, you should also avoid antithrombotic until the pellet less than 1,000. So we start cytoreductive first until the pellet is less than 1,000. Only then we start the anti-pellet. Okay, because of what we mentioned just now. And then if let's say patient develop any severe neurological symptom, thromboembolism, acute thromboembolism, or even like acquired von Willebrand syndrome, you should consider the patient to go for apheresis, which is a thrombocytopharesis. Okay, so this is also another point to inform to mention. Okay, so just want to go through thrombocytosis approach. So if I prepare the scenario outside, I will definitely write something like this similarly, because this kind of scenario is difficult. Just give you like just same as scenario of abnormal liver function, abnormal kidney function. So I actually in exam never really came out like abnormal full blood picture or full blood count before FVC. The exam scenario is more like abnormal liver function, abnormal kidney, and in liver it can be more like cholestatic or hepatocellular or mixed. In the kidney is more like just AKI lah, or on top of CKD, or sometimes may have some hemolysis evidence from the result. But generally, the exam really never shows any abnormal MBC lah. So that's why I think of perhaps we should come up with this kind of scenario. Because this kind of scenario basically have not much of chief complaint, and it don't. If you ask the patient may not tell you the chief complaint until you ask. So it tested us on the systemic review, and I'm glad that you managed to remember to ask about the vaccination in a post-splenectomy patient. Similar to patient, for example, thalassemia that underwent splenectomy, you should always ask about splenectomy. Okay, you should always ask about their vaccination, whether they complete or not, up to date or not. It's because they have a very high risk of infection. That's why it's important. Okay, and then if I prepare this scenario, I will write, for example, primary, and then I will write secondary. Secondary, I will branch into the field. For example, the IDA, because patient has anemia, I catch that patient is anemia. Patient can be IDA as well. Okay, and patient can have chronic inflammation, infection, trauma. Patient can also have functional asthenia, for example, like in the case of sickle cell anemia. So it's also important to ask about any blood disorder in the past, any family history of blood disorder in which you ask. And then you also need to ask about hemolysis. So you should ask whether whether you have any itchiness over your body, whether does anyone tell you that you appear a bit yellow than usual. All those are just like screening question. Even if you pass, you notice that your past urine actually more your urine seems to be more darker in color, and your stool seems to be like pale. This is to suggest the hyperbilirubinemia, but which may elevated in hemolysis. And then the age appropriate malignancy screening, that is definitely whether it's a hematological or solid organ. Hematological will automatically become primary lah. And then the rest of the solid organ malignancy will become the reactive. Okay, so any question, Ben?
Yeah, I think that's I'm okay. Thank you so much.
Yeah, I hope you learned something from that. So just some important things about the thrombocytosis lah. So cytoreductive basically got a few options, but I don't think exam we need to know that detail, because I don't think examiner will ask you which one to choose. But this is just some general knowledge that I feel is important to know. Hydroxyurea usually it can come out also, but I don't think it have came out before. But let's say the patient it came out as a communication skill scenario that the patient is like suggestive or confirm myoperipheral disorder with essential thrombocytosis, and your role is to counsel on cytoreductive, and your consultant have decided to start the patient hydroxyurea. So part of the thing that you need to mention in terms of precaution is to actually counsel the patient on the risk, the potential side effect. Oral ulcer is very important to counsel. Skin pigmentation is also important so that patient did not get anxious, and then rashes as well. And if the patient is pregnant or in a reproductive age group lady, then you should also talk about the pregnancy risk as well as the teratogenicity, which we shouldn't. Pregnancy or reproductive age group should go for PEG interferon. Okay, and then anagrelor is someone you don't want to start with the patient have heart failure or fluid overload, because it's not good for the heart. Okay, just remember something like that. But I don't think it will come out in exam. But the hydroxyurea can come out because it is something quite commonly prescribed in myoperipheral disorders. And then the rest of it actually no role. So you just remember these three. Antithrombotic, basically you give antiplatelet, let's say the platelet is less than 1,000, and you give anticoagulation, let's say there is a thrombosis. Okay, let's say got PE, got any confirmed thrombosis, then you give anticoagulation. And then when do we start apheresis? Generally, it depends on the institute whether they have the facility or not. But generally, if patient have neurological symptom due to microvascular disturbance, transient thromboembolism from here, or acquired von Willebrand, or just to bring down the platelet, if it's like very high, this is not like absolute indication. Or if let's say that for symptomatic relief, let's say patient got thrombosis as well as bleeding at the same time. Okay, so these are some few indication to start. And then so how do we diagnose ET is like how do we diagnose ET is like there's a lot of guidelines, okay, but basically the ERN is the one that we generally tend to use. So it's something similar to something similar to uh uh something similar to the what I want to mention is the polycythemia, okay, polycythemia vera. So in which high risk is definitely whether patient got thrombosis or elderly. Some they define as more than 60, some define as more than 50. Okay. And the newer criteria is more through you can see that moving towards genetic mutation as well as the age 60, as well as also depending on the gender. Male tend to be worse compared to female, and then the leukocyte. But I don't think you need to know those. And you can see the aspect guideline also mentioned about JAK2 MPL mutation. So if it's positive, definitely it's like confirmed and it's considered high risk. Okay. So it's important for you to know about this. And this is also just based on the guideline. If the platelet is like more than 1,000, ideally you should check for one ribbon screening. Or in clinical setting, practically we don't check. We just don't start the patient anti-platelet until the platelet is less than 1,000. Or after excluded acquired one ribbon syndrome, then you want to start, it is fine, but you need to monitor also for the bleeding risk. Generally, anything more than 1,500, you have to cycle reduce first before you consider starting. Okay, so I think Jolie asked about one question in the chat box. Should we admit the patient to start hydroxyurea and monitor as he has headache? Yeah, I mean, generally, the headache, you need to assess whether patient got any other hyperviscosity syndrome. Let's say patient got no active headache at the moment, and then you've got no other symptom from the history to suggest of hyperviscosity. I think you can still start the patient hydroxyurea as outpatient and monitor and see back in the clinic early to assess the side effect and so the response. But generally, let's say patient has a few indication to suggest hyperviscosities, mainly the symptom, then you really need to admit the patient because the patient may be indicated for apheresis therapy, like what we mentioned. Okay. So generally, if you are not very sure, you can mention about these two possibility in an exam. You don't have to commit, but generally you can say that if based on my assessment, you don't have any symptoms to suggest that uh, your blood is thick, and we can actually start you on some medication to lower down the counts, and then we'll see you early in the clinic. You can mention something like that. However, let's say we found that you have any symptom that may suggest you have high risk of developing a clot, then we may need to admit you. Okay. Sometimes in exam, when you address the patient concern, you don't have to answer yes or no. Okay, because sometimes you don't know or you're not very sure. Or even you can, if you're not very sure, you can also say that uh I, I'm not entirely sure at the moment. I would like to confirm with my consultant and then we will see how it goes. Okay. Instead of giving an answer that can be wrong and can be dangerous. Okay. So we will proceed with the case two. Case two is, I think it's Ui, right? Ui, are you there, Dr. Ui?
Hi, Dr. Jimin, I'm here. Can you hear me?
Yes, yes. Okay, so are you ready to start?
Yes, I'm ready.
Okay, yeah, so just give me some time. So we'll give you 4 minutes and your time start now.
Okay.
Okay, time's up. Dr. Uy, this is the patient, Miss Susan.
All right. Okay. Hi, I'm Uy. May I know I'm talking to Miss Susan, 28 years old.
Yeah, and Susan.
I've been understood that you have tummy pain. Can you tell me more?
Yeah, doctor. I've been having tummy pain about 1 week. So it actually just localized at my right side, lower side, and also my side of the, it's particularly at the right side only. And then it does not actually goes anywhere.
Okay, you mean right upper or lower?
It's a right the whole right side, the upper and lower side.
Upper and lower. I see.
It's also towards the back. Yeah.
Okay. So may I know, is it a sudden onset or a gradual onset?
I would say that it is actually gradual onset, but initially it's just a mild pain, but it actually increased in the intensity, and it actually has been persistent.
Okay. So how this pain feel like?
It feels like crampy, and then but it persists. It's not like episodic like that.
I see. Do you find anything that make the pain worse?
Not really.
Okay. Is there any specific timing of the tummy pain?
No, I mean throughout the day and night is painful.
Okay. Is there anything that can relieve the pain?
I try with some Panadol mainly, but it does not really help.
I see. How much would you like to score the pain? 0 is not painful, 5 is moderate, and 10 is very painful.
I would say it's about 6 to 8.
Is it the first time you have this abdominal tummy pain?
Yeah, it's my first.
Okay. Do you have a feeling of a vomit or do you vomit?
I do feel like want to vomit, but I didn't.
I see. Do you ever been told that your eye become yellow and skin is more yellow than other?
No.
Okay. May I know how is your bowel motion?
I still can pass motion.
Okay.
It has been the same.
Okay. How frequent you pass motion?
Almost daily.
Okay. So what is the color of your stool?
I think it's normal. It's just brown.
Okay. Is there any diarrhea or constipation?
No.
I see. Do you have any difficulty to swallow?
No.
Any ulcer? Oral ulcer? Oral sore?
No.
Okay. Do you have any fever?
Fever. No.
Okay. Do you ever be told that you are become more pale than usual?
No.
Any dizziness?
Dizziness. Not really.
Okay. Do you have any lumps and bumps?
No.
Any rashes, spot, or pigmentation?
No.
Any night sweats?
No.
Joint pain?
No.
How is your mood?
My mood has been quite sad because of this pain. I feel like it's very disabling for me.
I see. I hope I can help you to settle this problem after this consultation. Do you have any weather preference?
No.
Any shakiness of hands?
No.
I see. Okay. How about your water work?
Like as in?
Okay. Do you have any pain when you urination?
No, it has been painless.
Okay. What is the color of your urine?
Most of the time it's actually just like a normal urine color, but recently in the past 1 week also I noticed some passing of blood clots.
Okay. Do you ever passing of stone?
Stone? No.
I see. Okay. Any increase in frequency of
Um,
urine?
no, I think I'm just regular about 3 to 4 times per day.
I see. Do you wake up in the midnight to pee?
No,
Okay. Any sensation of like after you pee, you feel you haven't finished your urination?
no.
I see. So you say you're passing blood clot. How frequent you have this condition already?
Almost every day, doctor. In the
Almost
past.
every day. Okay. So is when the blood clot is like your urine is all red color or only blood clots?
I don't find any red color urine, but I do see some clots mixed with the urine.
I see. Okay. Yeah. Do you have any cough or runny nose?
No,
Do you ever coughing out blood?
no,
Do you have any chest pain or racing heartbeat?
no,
Any headache or blur vision?
no.
Okay. Uh, uh, Other than this, do you have any other side have bleeding tendency? Example, any bruises?
No,
I see. May I know, do you have been diagnosed to have any medical condition before?
no,
Have you ever been admitted?
no,
Have you ever underwent any procedure before?
no.
Okay. Uh, do you on any medication? Are you on any medication?
Um, the only medication I'm on is actually contraceptive pills, the birth control pills.
Okay. How long you already take this birth control pill?
Almost 3 to 4 years already. Because previously my menses wasn't very regular. That's why the doctor started me on this.
Okay. So any recent change in medication
No,
or recent added dose in medication?
no,
Do you ever take any traditional medicine or supplement from
no,
at the counter? Do you have any allergy?
no,
Okay. Do you have any family history of have a similar condition like you?
no, no,
Any family history of bleeding problem?
no.
Any inherited disease run in your family?
No family disease that I know.
Okay. May I know what you do for a living?
Yeah, I work as a banker.
You as a banker. May I know have you married? Are you married?
I'm actually in a relationship and plan to get married next year.
Plan to get married next year. I see. Okay. Do you smoke or drink?
No.
Okay. May I know how this condition affect your work and daily life?
Yeah, I feel very uneasy because this tummy pain has been persistent and it's already 1 week. And I really don't know why is it happen, doctor. It has affect my work. Cannot really work focus. And then I also got scolded recently by my supervisor.
I see. It seems this condition has affect you really much. I would like to further explore on your menses. So how's your menses right now?
It's regular, doctor.
It's regular. Now already regular after you take this medication.
Yeah, yeah.
Okay. May I know, I know you are not married. May I know, have you been pregnant before?
No, no, no.
I see. Can I examine you?
Yeah, sure.
Okay. General condition is patient get sick.
No. Patient is a young lady, and then she appears well.
Right. I want to examine the hands. Any clamping
No,
period.
no,
Okay. Any palmar erythema.
no pulmonary edema.
Okay. Pulse. How's the pulse?
Pulse volume is good.
Okay. Heart rate and the vital sign is the same outside.
Yeah, it's the same.
Okay. Um, I want to look on the eye. Is there any pallor or jaundice?
There's no pallor or jaundice, but you do notice the eye is a bit puffy.
The eyes is puffy. I see. Okay. So, is there any oral sore?
No,
Okay. So I want to examine the tummy. So, is there any scar or bruises,
no,
deformity? Okay.
no.
I want to check the tummy. Is there any hepatosplenomegaly?
There's no hepatosplenomegaly, but when you palpate the right hypochondrial region, it's actually tender.
Tender on the right. Okay. Um, okay. So, may I check any palpable kidney,
There's no palpable kidney,
any palpable bladder?
no palpable bladder.
I want to check the back. Is there any tenderness over the renal angle?
Yeah, at the right flank, it's actually tender.
Okay. Any leg swelling? Leg
Yes,
edema?
there is a bilateral pedal edema.
Okay. Up to where?
From a general inspection, when you examine, it's actually up to the shin.
Okay. Is there any crepitation over the lungs vibratiously?
Yes, as you listen to the lungs, if you can appreciate that there's a fine crepitation at the both bases.
I see. Okay. So may I know, do you feel breathless?
Yeah, doctor. When I walk long distance, I do feel breathless.
So, how long you have this condition already?
Like I say, it's about 1 week.
It's about 1 week as well. All right. Okay. So, do you have any when you lie down, how many pillow you need?
I actually need about 2 pillow because I
2
don't
pillow.
feel comfortable with 1 pillow.
Okay. Any breakout in the midnight because of breathlessness?
Sorry, any what?
Have you ever wake up in the middle of night
Oh,
because of
wake up. No, no.
breathlessness? No. Okay. Go back to the urine. Do you ever feel that you have bubble in the urine?
Mm, I don't know whether it's considered bubble, but it does appear frothy before I notice any clot.
I see. Okay. Okay. So, may I know, do you have any taken any painkiller before? Are you
I've only
paracetamol?
Panadol. Yeah, only Panadol.
Only Panadol. I see. May I know your concern?
Yeah, doctor, what is wrong with me?
I see. So, based on my history taking an examination, I think you might have a kidney impairment. I need to further work out to know exactly what happened. For what I can tell is maybe you have a condition called nephritic or nephrotic syndrome.
2 minutes left.
Yeah, this is a condition where there is some impairment in your kidneys. So the underlying causes need a further blood test and imaging test to confirm, and we need to gather more information to tell you further. Yeah. Any other
Doctor,
questions?
what is the meaning of nephritic or this nephrotic syndrome, doctor?
It's basically um, um, in the structure of a kidney, there might be some damage and causing you to have these blood clots and also frothy urine. Yeah. Mm. And
Okay.
another thing is I need to rule out whether is there any stone in your waterworks system.
Okay.
So I
Do,
need a
do I need
further.
admission?
Yes, for now I need to admit you, okay, because you do have a symptom like breathlessness, okay, and yeah. So yeah, you need an admission. Yeah.
What is the next step for me after admission, doctor?
So I need to do a blood test and further imaging test, including a jelly gel test on your kidney or waterwork system to look further. And if we have not able to identify any causes, we need to take a sample from your kidneys.
Oh, okay, okay. But doctor, can I get pregnant?
For now, it's a little bit difficult for me to tell. I need to gather more information. Yeah. After that, then only we can tell you further.
Yeah, doctor. Do you think I need any blood thinners because I have clots in my urine?
For now, I don't think you need blood thinner.
Okay. Okay, time's up. So, Dr. Uy, would you mind to tell us regarding your differential diagnosis and your most likely diagnosis?
So I think this patient might have a nephritic syndrome. My differential diagnosis will be a nephrotic syndrome. Yeah, I need to rule out whether patient got underlying autoimmune disease. Yeah.
Okay. Any other differential?
Any other differential is maybe is a acute on chronic kidney disease with fluid overload may be secondary to kidney stone.
Oh, okay, kidney stone. But patient never have complained of any pain before this?
Yes, the patient never complained of pain before this. Yes.
So perhaps you'll be lower down the list. Any other differential?
Other differential can be renal vein thrombosis.
Okay, because?
Maybe due to the underlying nephritic syndrome, generalized edema, hypoalbuminemia, may predispose patient to have this condition, and that's why have pain and blood clot in the urine. I think so.
Okay. How will you investigate this patient?
So first of all is full blood count to look for any anemia or infection, inflammatory marker, ESR, CRP, renal profile to look how bad is the kidney have been impaired, and liver function test to look for any liver dysfunction. I like to find out the etiology. So first, I like to look for the autoimmune screening, which is ANA and also ENA, C3, C4. I like to also order ultrasound clinics to look for any parenchyma disease or any kidney stone. And also consider the invasive one, which is a renal biopsy.
How about urine?
Yes, urine I like to take for urine FME to look for proteinuria, and also a urine PCR and proceed with urine 24-hour urine protein. Yeah.
Okay. If you are suspecting things like, for example, renal vein thrombosis, is there any test you want to order? Is the ultrasound enough?
I'm not sure, but renal ultrasound plus Doppler maybe can pick up this.
Okay, all right, okay. So you mentioned about the kidney biopsy. So what are the possible things that you will find if you do a kidney biopsy?
Glomerulonephritis.
Glomerulonephritis. Okay, that's a very general term. So do you think the patient have nephritic or nephrotic syndrome?
Can be a mixed picture, but I would can be a mixed picture, but more toward nephrotic.
Then to explain the hematuria.
Hematuria, I'm not really sure. Yeah, not really sure.
Okay, how will you manage this patient?
First, I will go for non-pharmacological. First, which is a patient education and counseling regarding her condition, and then involve a multidiscipline approach whereas like to involve dietitian and also nephrologist. And pharmacological wise, is first is a symptomatic treatment first. I consider to relieve the fluid overload by giving LASIK, and also start prednisolone for the nephrotic syndrome.
Okay. So you will start prednisolone straight before you know the diagnosis.
No, after a kidney biopsy.
Okay. So if you think this is nephrotic, you want to start prednisolone only? Okay, never mind. Any other management?
Yeah, other management will be after the result of kidney biopsy, refer to nephrologist to treat the underlying causes. Patient might require immunosuppression. Yeah.
Okay. So yeah, I mean, okay, but generally you know the kidney biopsy is done by nephrologists, right?
Yes, yes.
Yeah, so you should mention you refer to nephrology team to begin with, instead of like referring that after the renal biopsy.
Oh, yes, yes.
I think you are quite okay though. Just that you need a bit of prompting, and you are very undecisive. I can see during the session, your diagnosis is changing, and then you're trying to link everything. But not too bad. I can see that you are trying to think as you go along. But the idea is you need to think before you speak, if possible. Okay, because when you think along, when you speak, things may change, and the diagnosis may change as well. Okay, so if I going to grade you, right, or even before I talk about mark sheet, how do you feel about this scenario?
Difficult for me. Difficult.
Difficult, but not too bad, I feel. Okay. And do you think is there anything that you may improve in terms of the history taking, for example? You use actually about completely about 9 minutes of history taking. So I don't know whether in real exam, whether when you examine the abdomen, you still got enough time. But generally, like I mentioned, right? So try to aim 7 to 8 if possible. But if not possible, you still can get diagnosis. The history is still most important thing. It's okay to go up to 9 minutes, but your examination must be smooth and must be try to as complete as possible. You must aim for one system other than peripheral examination, and then you can examine the rest of it after you aim to finish the main examination. So from the history, do you think you missed anything?
I didn't ask SLE symptom. I think
The autoimmune, but I remember you only asked about joint pain.
joint
You
pain
didn't ask
and
about,
rashes. Yeah, I didn't ask more.
yeah, I didn't ask further. Okay, that is fine. And then how about fluid overload symptom at all?
Yeah, after I examine, you tell me puffiness, then only I go back to
The reason is being sometimes when you so focus on looking at conjunctival panel and scleral jaundice, you may even miss a periorbital edema. If you're not thinking of it, you may miss it. But I decided to give you a clue because I'm not showing a real patient. But even if you see a real patient, remember that you may miss it if the periorbital edema is not obvious. So the idea is when you encounter a patient with kidney issues, like for example, hematuria per se is already a kidney symptom, right? And then what is the chief complaint? The chief complaint is abdominal pain. So you got right hypochondriac pain with hematuria. You need to really screen all sorts of possibility. It can be nephrotic, it can be nephritic. Is it possible nephrotic have hematuria?
Still possible. But definition wise, they usually will not say there's hematuria.
Yeah, I mean still possible. Usually, if nephrotic have hematuria, it usually means the patient may also have some AKI already. So if the patient have nephrotic with AKI condition, usually nephrotic can be just normal kidney function. Okay, but let's say nephrotic have with AKI, what is the differential?
Nephrotic AKI was my differential.
Because you really need to think about this nephrotic with AKI as compared to nephrotic without AKI. This scenario, I choose not to give any urea or creatinine level just to make the scenario a bit challenging. But generally, the idea is the same. usually in the pure classic nephrotic syndrome, you should not expect any active urine sediment, including the hematuria lah. Let's say there is a hematuria, is already give clue that yes, this can be mixed nephrotic syndrome that you mentioned, but in exam you need to try your best to really decide which one, because the etiology can be very different, right? And then nephrotic with AKI, there's not much of differential. Okay, but the important differential that you really need to think of is actually whether you're dealing with nephrotic can be minimal change, can be membranous, can be FSGS, right? These three. And the commonest is still being the minimal change. It can be minimal change with some form of thrombosis, like renal vein thrombosis. Then yes, you can get AKI, you can get active urine sediment. How about any other possibility? Yes, if patient is fully overloaded, you can get nephronia, in which there is a perinephric congestion or renal congestion together with nephrotic. Then yes, it can also lead to AKI as well. How about any other? Do you know any other cause?
I don't know. Sorry.
But it's okay. It's not that important. The idea that is actually if let's say you are dealing with fluid overload symptom together with like hematuria, you need to know which one started first. And in this patient, I told you clearly, like, I mean, the frothy urine seems to come before the blood, right? So that give you a clue that, okay, this may be like nephrotic and then develop into some form of AKI or even nephritis. If you're not sure, you can mention glomerulonephritis as your differential. It's not wrong, but ideally you will want to differentiate. Okay, so this patient actually has a renal vein thrombosis because the reason is tender when you palpate the renal angle, and then but you didn't auscultate the kidney. I expect you to auscultate, right? You didn't auscultate. You want to hear whether there's any renal bruit. But if you mention that actually no, usually the renal vein thrombosis usually have no renal bruit. Okay, and then yeah, another thing is then we will discuss as we go along. So in terms of the mark sheet part, right, I think your comm skill is okay. Intermittently you accidentally use some jargon, but you try to correct it. I think it's fine, but try not to use it too frequently. If possible, not to use at all. So you must think a bit before you mention. So you must practice more. I think your flow is there. Just that your systemic review for example, the renal symptom is not complete. The renal symptom can never complete without any fluid overload symptom because nephrotic is still common. You encounter a possible renal scenario, you want to ask about the fluid overload part to suggest a nephrotic syndrome. If let's say there is a nephrotic syndrome, you want to ask further in terms of complication whether there's any thrombosis, okay, whether there's any history of clot, things like that, any pain over your leg. So all those things must be asked. And then let's say there is not much of fluid overload symptom, it's just like pain with some blood in the urine. Yes, it can be UTI, it can be renal calculi, or it can be nephritic syndrome. Okay, then nephritic you're talking about, it can be IgA nephropathy, or this can be post-infectious GN. Now we don't use the term like post-strep GN anymore. We use post-infectious GN, PIGN. In general, a lot of infection can be staph, can be strep, can be other thing. Okay, those are called post-infectious GN. And then, so how you differentiate these two is to ask the symptom. You have to ask any URTI symptom. So in general, IgA nephropathy as compared to post-strep GN, right? So the IgA forms very fast, so they are very thin pharyngitic. So meaning to say that if patient has hematuria, usually they have also flu-like symptom occur concurrently, as opposed to post-strep GN, in which the antibody develops later on, like within 2 weeks, or the guideline always says the typical is 10 to 14 days. So you should able to get this type of history to differentiate. And the one is to try to see whether patient have any analgesic or drug-induced nephropathy that may suggest a nephritic syndrome as well. So when I ask about the drug, yes, you ask about drug as well. And then you also need to ask about autoimmune symptom, malignancy screening, as well as any vasculitis. Aspergillus and autoimmune is kind of like overlap in terms of the symptom, but generally you need to explore a bit. Like for example, you're thinking about ANCA-associated vasculitis, you want to ask about whether there's any nose block, whether there's any, do you notice any change in your nose shape, or do you notice any difficulty to breathe, or anyone told you to have any form of like asthma, chest tightness, like that was started recently? Do you have any numbness over your peripheral to may suggest the mononeuritis multiplex in Kussmaul syndrome, or the new name is EGPA? So this is part of the vasculitis. And then after that, what are the other possibility in nephritic? It can be SLE. You have mentioned the coronary tissue screening is fine. It can also be things like GBM. So you want to ask whether there any coughing of blood in the lung, whether there is cough of blood. That may suggest good postural syndrome. And then you may also want to ask regarding the symptom, whether this is the first time. I think you asked also, is it the first time or this is like a recurrent episode? So if let's say this is a recurrent episode, there's family history, also got hearing loss, then you're thinking about Alport syndrome. Oh, let's say the patient, you feel that the patient also have family history of kidney disease, you palpate the liver, palpate the abdomen, there is a bilateral kidney, then you're thinking more to adult polycystic kidney disease with possibility of infected cyst or bleeding into the cyst, causing hematuria, and also may have some form of kidney impairment that can explain the fluid overload. Okay, so you generally need to go by your approach. Okay.
Okay.
So in terms of your mark sheet, I would say just to continue back, your com skill, I would say okay. Your examination is okay as well. Judgment, I would still give 1 because you have difficulty to decide your primary diagnosis. Concern, I think you address most, and then physical sign is fine. You manage to appreciate that there is a renal angle tenderness.
Okay.
And differential diagnosis, yes, I think I will give 2 as well. Generally, you are quite good. If based on marking scheme, you are good. It's just that your clinical judgment and also your differential diagnosis, these two need to work on further. Okay. And
Thank you.
then this is a bit, yeah, thank you. So this is a bit on the marking scheme now, huh? So the important thing is actually try to elicit whether there's any fluid overload symptom. Okay. And then yes, you have tried to exclude infection like UTI, renal stone, coronary tissue screen. Probably not all, but at least you managed to ask for joint pain and rash. And then drugs, and also no other illicit drug use. Gynae part, yes, patient is on OCP. The clue is the patient is on OCP and now developed nephrotic syndrome. So definitely the thromboembolic risk is even higher. So that's also another thing that you may want to sell to the examiner, that the examiner say, if you think this renal thrombosis, what might be the cause? Nephritic syndrome per se does not lead to thromboembolism, but nephrotic, yes. Okay, because of the loss of these anticoagulation factors, so that predispose patient to clot. And yes, examination, you manage to elicit patients in overload, periorbital edema is the one I give clue. And then abdomen tenderness, if you want to examine for shipping downers, you can as well. And then I notice everyone tend to be a bit template based. When you examine, you just examine only. So usually when I do the examination, right, I will always think about fundoscopy and whether I need to mention or not. After I examine, right, I will tell the examiner that I will end my examination by performing a bedside urine dip and also fundoscopy. For example, let's say patient is hypertensive nephropathy or even diabetic nephropathy. So just mention that routinely. You don't have to wait until investigation only you mention. Like for your case, right, you exactly wait for the investigation and you didn't mention anything about urine. That is very dangerous. It's very dangerous. You need to mention that. Okay. UFAM is very important because it gives you a clue that whether this is a contain active urine sediment or whether this is overt proteinuria. Okay. And then you want to quantify it, you should mention it early because of fluid overload. You want to quantify it. You should also mention things like VBG, other than kidney function, because you want to know whether this patient has a very bad AKI and whether patient indicated for renal replacement therapy or not for temporary measures. Infective screening, do you mention it?
No, I didn't mention.
Yeah. So post-infectious GN also one of the things we should mention. Okay, because we know that hepatitis C can cause cryoglobulinemia. Those can also cause nephritic like picture. And then CTD screening, renal biopsy, yes. Ultrasound, KUB alone is not enough. You should mention ultrasound with doctor because you're suspecting this is a nephrotic syndrome with right renal vein thrombosis. Okay, and then sometimes even confirm, depending on the kidney function, you may want to mention about CT angiography, but if the kidney is impaired, you may not want to do it if the ultrasound Doppler is good enough. So this patient may not just need renal consult, also need hemato consult because of renal vein thrombosis. It's a thrombosis of unusual site. Okay, so but we know that the cause can be due to nephrotic syndrome because it's a young young thrombosis, you can argue that this can be provoked by OCP usage, but generally OCP is just a risk factor. It's not really a cause. So when you encounter a risk, a diagnosis of thrombosis, a young thrombosis, so you should try to exclude all the thromboembolic causes that would also include nephrotic syndrome, inflammatory bowel disease, paroxysmal nocturnal hemoglobinuria that can also explain the hematuria, but usually occur early morning upon first maturation or when the patient pass urine in the morning. Okay, and it can also be due to other things, for example, myeloproliferative disease, lymphoma. So those patients can also lead to thromboembolic disorder or even any cancer or malignancy associated, which is less likely. And then in your young lady, you should ask about the pregnancy social part, because this one you ask, yes, you ask about pregnancy, not in pregnancy. But let's say patient is in pregnancy, you need to really know that whether this can be APLS, that predisposed patient to thrombosis. Okay, APLS is very important. One of the important differential diagnosis if you are thinking of thrombosis, a young thrombosis. Okay, so other thing important perhaps is to know the precipitating factor other than OCP, and ask whether patient got recently traveled to anywhere by flight or immobilization, any surgery done before. I think you asked about all that, but the traveling history not really. Okay, this is also something just to make the history complete.
Okay.
Sometimes you will realize that if the history like 7 to 8 minutes is quite tight, but generally if your approach is structured enough, you will still manage to do it within the short time. The idea is to train yourself until you try to cover most of the important thing in the history. Okay, and then the management anticoagulation is also important to discuss. Not to initiate, you need to discuss, because let's say patient got hematuria, perhaps it's not a good idea to give anticoagulation. But let's say there's a renal vein thrombosis, then you really need to talk about it. And if the patient has, for example, any other thrombosis, you may also consider local thrombolysis or even catheter thrombectomy. For renal vein thrombosis, there is a two school of thought depending on the condition. Some they will recommend to start medical therapy with anticoagulation. Some depending on the kidney function. Let's say the kidney function is very still normal, but then the thrombosis is very severe. You may consider referring to interventional radiologist for catheter-directed thrombectomy on that renal vein. So it can be very different. Okay, and the duration of anticoagulation also depends. And immunosuppression, yes, if you suspect it's a minimal chain disease, then it's steroid only. But let's say this is a membranous GN, it's no longer just steroid. It's steroid with cyclophosphamide, the common modified Pontocerebral regime. But generally, I don't think you need to go into too detail. You just need to mention about immunosuppression. To me, I feel safer to mention immunosuppression instead of mentioning in particular medication. Let's say you suddenly encounter this scenario, one of the examiners is nephrologist, then he will definitely ask you a bit more. But I feel generally as a general guideline, we need to know what are the things that we need to give lah. Okay, just a general principle lah, just to say immunosuppression. Let's say examiner ask you further, only you mention. Okay, and then let's say the patient asks like, as he asks you, do I need a blood thinner for lifelong? Right? If you know that this is a nephrotic syndrome with thrombosis, according to KDIGO guideline, if the albumin is like less than 20, or the severely or if it's a frank proteinuria and there's also thrombosis, either one of it, you definitely need to start the patient on prophylactic anticoagulation. Okay, typically the one that we use is a low molecular weight heparin, but definitely how long we should start the patient in nephrotic syndrome, there's no definite guideline, but the usual recommendation is at least 6 to 12 months until the nephrotic syndrome, which is the underlying cause that trigger the thrombosis, is in remission. The disease itself is in remission, or the albumin level is more than 30, then you can off it. Okay, so this is all based on the guideline and something to test in terms of the clinical judgment, in terms of the knowledge. Okay, so I think that's all. Do you have any question, Dr. Wee?
No, thank you, Dr. Jimmy.
Yeah, okay. I hope you learned something. Yeah, but I think generally you're good. You just need to practice more. Just make your question more concise. I also noticed that when the surrogate asks you concern, you try to answer very lengthy explanation as well. Try to make it concise, and try not to use medical jargon. If you know that this is jargon and you mention it, you try to following after. You try to explain in the next sentence in a simpler layman term. I feel that if you mention that I think you have nephrotic syndrome per se is like a jargon. You should tell that I think you have this may have this condition called nephrotic syndrome in which your kidney leaks excessive amount of protein or even the membrane that filters the substance become very leaky and it tends to lose a lot of protein or even bloods, and that may explain why you're having all these symptoms. Or you want to make it short, also you can just stop at there and wait for the next question. So sometimes you don't have to explain in a lengthy because you imagine you only have 2 minutes to address at least 3 to 5 concerns. So you need to budget your time, no? So
Right.
the rules of the exam is like try to know the timing and then try to play with the rules, then you will be fine. Okay?
All right.
Okay, thank you. So
Thank you.
next candidate, yeah, thank you. Next candidate will be, yeah, I think is Chris, right? Chris, are you there? Or Chris still haven't signed in yet? Yeah. Hello, Chris there. I think you are unmute already. Can you hear us? I can't hear your voice.
Hello?
Hello, yeah, Chris. Yeah.
Hello, can you hear me?
Yes, yes, I can hear you now. So are you ready to start the scenario? Are you ready?
Hello?
Hello, yeah. Are you ready to start?
Hello?
Okay.
Hello?
Can you hear my voice?
Hello, can you hear me? Hello?
Yeah, I can hear you. I can hear you. Can
Okay.
you hear me? Us?
Yeah.
Can you hear us?
Can.
You can, right? So I will give you 4 minutes and then your time start now.
Okay.
Okay, time's up. So, yeah, this is a patient, Mr. Parkson. Please start.
Good evening, Mr. Parkson. I'm Dr. Teh. I'm a doctor in the acute medical unit. May I confirm, are you Mr. Parkson, 45 years old?
Yeah, I'm Parkson.
Hi, I understand that you came here for chest pain for 1 month. Can you tell me more about this?
Yeah, doctor. I've been having intermittent chest pain for the past 1 month. It usually occurs at rest when I just lying, and then it localized to the left side of my chest. And every time this episode happened, it actually lasted about 15 to 20 minutes, and then subsequently it resolved by itself. So it also is, have associated with a lot of sweating over my whole body, and also I do feel a bit of racing of my heartbeat.
Okay. Thank you for telling me this. It must be very difficult for you. Let's hope that we
Yeah.
can get to the bottom of this problem and help you. May I ask, when the pain occur, what were you doing?
Yeah, I'm just resting.
Resting. Okay.
Mm.
May I ask, is this your first time having such a problem, chest pain?
For the past 1 month only.
Okay. Previously, you never had any chest pain before. Am I right?
Yeah, no.
Okay. May I ask, when the pain occur, on a scale of 0 to 10, 0 being no pain, 10 being the most painful, what would be your pain score?
It usually is about 5 to 6.
Okay. Um, you mentioned that it resolved spontaneously. Am I right?
Yeah.
Usually, when the pain start, do you do anything to try to relieve the pain?
No, I have tried like things like paracetamol, but it does not really helps.
Okay. Anything that worsen the pain, like when you try to walk further, try to do some work, do you feel the pain getting worse?
Yeah, I do feel if I try to exert myself, yes, it tends to get worse.
Okay. May I ask, do you have any breathlessness?
No,
May I ask, do you at night time, do you frequently wake up at night time catching a breath?
no,
Any problem with breathlessness lying down?
no,
Any leg swelling?
no,
Any fever?
no,
Any vomiting?
no.
The pain, may I ask, does the pain radiate to anywhere? Like spread to anywhere? Like spread to your left arm or your neck?
Yeah. Sometimes it spread to my left side of the arm, and also sometimes can go up to my jaw.
Okay. Any cough?
No,
Any what do you call that? History of coughing out. A blood in sputum. A blood in your phlegm.
no.
Any body rash or spots or pigmentation.
One by one, no rash, no spot, no pigmentation.
Okay. Any swelling or lumps and bumps on the body.
No,
Okay. Any tummy pain.
no,
Any problem with your bowel habit, like any diarrhea or constipation.
no,
Is there any problem with your waterworks, like your urination?
no,
Okay. Any body weakness?
no,
Any headache?
no,
Any body numbness?
no,
Blurring of vision?
no.
Any mood change recently?
No,
Okay. Is there any problem with your vision?
no,
Any eye redness or eye pain?
no,
Any mouth ulcer?
no,
Any joint pain?
no,
Okay. Is there any change in your weight recently?
no. That's been static.
Okay. Is there any problem with hand shakiness?
No.
Okay. Mr. Parkinson, may I ask, is there any medical condition that I should be aware of?
Yeah, doctor, I have diabetes.
Diabetes. May I ask, diabetes was how long already?
Diabetes has been almost 5 years.
May I ask, what medication are you taking for diabetes?
I'm only taking metformin, 2 tablets, twice a day.
How has your sugar been? The sugar control been? Is there any reading?
Oh, I just have a sugar check, which shows the 3 month sugar control. The doctor told me 6.5.
Okay. Have you been ever admitted for any problem with like a heart stroke or any heart problem before?
No, no.
Okay. Have you underwent any checkup on your eye before?
Yeah. Last I checked out was early this year. It was normal.
Okay. Any numbness over the fingers and foot and feet?
No,
Okay. Any feeling of bubble in urine?
no.
Okay. Um, is there any other medical condition that I should be aware of?
Yeah, my family members tends to have blood disorder, doctor. My brother have a sickle cell anemia, and I went through some blood check as well, but they told me I just have a sickle cell trait lah, and I never require transfusion before.
Okay. May I ask, how about your siblings that have sickle cell anemia? Do they have any problem? Any problem with pain over the chest?
Yeah, my brother tends to have chest pain, tummy pain, everywhere pain lah. But then this is something new for me lah.
Okay. Is there any other problem? Any other medical condition I should be aware of?
No, no, no,
No more. Have you been hospitalized for any problem?
no,
Okay. Any previous operation or surgery done?
no,
Apart from metformin, are you taking any other medication?
no,
Any history of taking over-the-counter medication or any supplements?
no,
Okay. Is there any other disease apart from the sickle cell anemia? Is there any other disease running in the family?
no.
Okay. Okay, Mr. Parson, may I ask, do you smoke?
No. Sorry. I do smoke. I smoke about 1 pack per day.
How many years have you been smoking?
Almost 10 years.
Do you consume alcohol?
No.
May I ask what's your occupation, Mr. Parson?
Yeah, I'm a businessman. I frequently travel, doctor.
Okay. Any recent, you mentioned that you frequently travel. Any recent travel?
Yeah. I just went to Australia. Just went back from there 2 weeks ago.
Okay. May I ask, are you married?
No.
Do you have any, are you in any relationship?
No.
Okay. Sorry for asking, but may I ask, do you take any illicit drugs?
Doctor, why you ask this?
I'm sorry for asking you, but I think this question I usually ask for all my patients. It might help to get into my diagnosis. Sorry if it offended you in any way.
Yeah, I don't know why you have to ask this.
Okay, I'm very sorry.
But since you asked, I have to tell you that I did take cocaine with my friends last night.
Cocaine. Okay. May I ask how is this your first time taking cocaine?
No. I have been taking the cocaine for almost 2 months already.
Okay. May I ask how much do you take the cocaine? Like how many tablet you take?
It is not tablet. It is not tablet. But we usually take quite a amount. I can't exactly tell you because I will take cocaine until I high, and then all my friends will be together with me.
Okay. Okay. Thank you for telling me. I would like to start examining Mr. Parson.
Okay.
May I ask for the general appearance? I see how is the body build?
Average build.
Average build. Okay, I would like to check on the pulse. Is the pulse regular?
Yes.
How's the pulse volume?
Pulse volume is good.
Okay. I will check on the eyes. Any conjunctival failure or jaundice?
No pallor, no jaundice.
Okay. Any rashes on the face?
No.
Okay. Any cyanosis, central cyanosis or peripheral cyanosis?
No.
Okay. Any periorbital puffiness?
No.
Okay. I want to check the JVP. Is the JVP raised?
No.
Okay. I want to check on the pre-contact examination. Is the any murmur on the heart on our consultation?
So when auscultate the heart, the S1, S2 is heard. There's no added murmurs.
Okay. Any bibasal crepidation on lung auscultation?
Lungs is clear.
Okay. I want to examine abdomen for any hepatosplenomegaly.
There's no hepato or splenomegaly.
Okay. The next will be any leg edema.
There's no pedal edema.
Okay. Mr. Parson, may I ask what is your concern?
Yeah, doctor. Do I have heart attack?
In based on my assessment, I think that there's a possibility that you might have a heart attack because you have a risk factor of diabetes.
Okay. So I can have a heart attack. And do I need admission then?
I think you need admission. Number one is we want to look. I want to try to make sure that you don't have any heart attack, and we want to keep you closely monitored because you have consumed cocaine recently. So I'm afraid that it will cause any problems, especially to your heart, in the recent next few days.
Okay. But can this symptom be due to my brother like having a sickle cell problem?
Yes, definitely. This sickle cell trait,
2 minutes left.
trait, it might actually cause some problem to your blood shape, and when the blood shape is abnormal, it will tend to have symptoms on your chest as well.
Doctor, will this chest pain occur again later on?
It depends on the cause. Once you are able to identify the cause and treat it accordingly, then the chest pain might not be occur anymore.
But what should I do? Like, anything I need to be anything that need to be done, or I need to be worked out first?
So far, I will have to admit you, and we'll get some take some blood and do some tests to look for any heart attack, and also at the same time, I want to rule out. I want to look for any sickle cell disease as well, currently affecting you, and we'll do also a heart scan to look for any heart scan to look for any problem with your heart.
Okay, doctor. So I will discount 1 minute plus because of the examination. Okay, so time's up. So yeah, Dr. Chris, would you mind to tell me what is your differential diagnosis and most likely diagnosis in this patient?
My provisional diagnosis for Mr. Parkson will be acute coronary syndrome, most likely cocaine induced, or with underlying diabetes, which is partially controlled.
Okay, you have mentioned this can be acute coronary syndrome, right? What are the risk factors for acute coronary syndrome other than diabetes?
And also, he has a recent cocaine intake that might precipitate the acute MI as well.
Okay, any other risk factor?
Smoking. He's smoking for 10 years.
So have you counseled the patient to stop cocaine, to stop smoking?
Yeah, I didn't mention during the concern part.
Okay, no problem. So any other differential diagnosis?
My differential diagnosis next will be sickle cell crisis, with due to underlying sickle cell trait.
Okay. Okay, but is it likely?
Is unlikely because she's just a sickle cell trait.
Okay. And is there any other differential?
Other differential diagnosis will be pulmonary embolism because of the prolonged traveling. Because he's a businessman with a prolonged history of traveling, so there might be a risk factor of causing a pulmonary embolism. but there's no pedal edema that suggests DVT.
Oh, but DVT also will not have pedal edema, right? Sometimes you just have calf
Sorry,
edema.
leg swelling. Sorry, I mean.
Okay. So any other differential for chest pain?
I think lung infarct, but it will be down in the list. Down in the list.
Okay, all right. How do we investigate this patient?
For the investigation to confirm the diagnosis of acute coronary syndrome, I will do an ECG to look for ST changes. I will send a cardiac enzymes, and I will do a echo to look for the heart function and also any regional wall motion abnormality. I will do a chest X-ray. Chest X-ray particularly to look for any features of a lung infarct or any features of acute pulmonary edema, but clinically patient doesn't have any lung palpitation. At the same time, I will do a FPC, CRP, ESR to look for infection. I will send a PVF as well to look for sickle cell trait, and I will send also for urine toxicology to look for cocaine.
Oh, okay. Do we have that?
I'm actually not really sure.
How will you confirm patient is like sickle cell disease other than PBF?
I'm not sure.
Okay, never mind. And any other tests?
Renal profile to look for any AKI due to the
Sorry, what ATI?
renal profile to look for any acute kidney injury.
Okay.
Okay.
That's all?
That's all from.
Let's say the ECG is normal, Trop-I is not elevated. What is your next step?
Next step, I will probably consult cardiology to look for any role of chorus or angiogram.
Okay. Any reason for that?
Because of the risk factor. So I think he might have acute coronary syndrome, so he warrants chorus or angiogram. Next would be pulmonary edema, pulmonary embolism will be CTPA and D-dimer.
But we don't immediately go to CTPA, right? So so you should see whether the well score, calculate the well score. If it's high, then it's only CTPA.
Yes.
If your well score is low by your clinical suspicion, then you go for D-dimer. If positive, then go for CTPA, right? So not something to go immediately. So what is the importance of angiogram in this scenario with a normal Trop-I and normal ECG?
If let's say the chorus is normal, it means that most likely is cocaine induced vasospasm.
Okay, all right. Non-obstructive. Okay. So what was your management? If let's say this is it.
Sorry.
If let's say this is the diagnosis, what is your management?
I will advise patient to stop cocaine, and I will admit the patient to the hospital for closer monitoring. And run the test that I mentioned just now. Once the diagnosis is confirmed,
so do you need to start antiplatelet or not? Okay, time's up, but continue.
He still has a risk factor, so I think need to start aspirin.
Oh, is it?
I also consult cardiology team first before starting.
No lah. I already told you the angiogram is like you told me the angiogram is to differentiate, right? So I tell you the diagnosis is if the diagnosis is cocaine induced, meaning to say normal angiogram lah. So but there's no rule to start antiplatelet. The risk factor can optimize, right? The optimization of risk factor does not include starting an antiplatelet, right? Antiplatelet, if let's say there is plaque, okay? There's atherosclerotic plaque, and there is a intimal thickening plaque, and all those then may suggest the role of aspirin lah. Oh? Okay, good. I would say your performance is good. It's really good. I would say you managed to get the part that you almost miss it, the illicit drug use. I thought you at one point of time I thought you will miss it because you asked about over the counter, traditional, and then social, and then only then you ask about illicit drug. Okay, that's good. You managed to get it. So, but how do you know whether this is cocaine-induced coronary vasospasm versus a true ACS? You managed to get the history of cocaine use, right?
Yeah.
But you did not elicit the temporal relationship, you know?
Because he said 2 months, 2 months of cocaine
No.
use.
How long?
Then,
How long has been taking? For the past 2 months has been taking.
yeah.
But you should ask further that. I understand that you have multiple episodes of chest pain. Does all the chest pain actually happens after you take the cocaine? That can easily get the diagnosis of cocaine-induced vasospasm, and the answer is yes, right? Because usually vasospasm is a transient finding. Oh, so after they take cocaine, only within 1 or 2 days time they will get this intermittent chest pain, and then usually after that it resolves by itself as the half-life reduce lah. So you need to elicit that temporal relationship. It's not just good enough that you're happy that you get the cause. Okay.
Okay.
All right. So I think your performance is good. Nothing much from my side to add on. Your communication skill, I would say okay, but when you get nervous, I can see that you will accidentally say 1 or 2 jargon. Try to avoid that, but generally it's fine. Examination, I think is good. Your flow of thought is good, and then you're fast. But in the real exam, remember that you cannot just do auscultation in the CVS finding lah. So your predominant issue is chief complaint is chest pain, and your main physical examinations is more to cardio, right? You really need to at least try to feel for a backbeat, feel a bit, and then only then you auscultate for any murmurs, and then only then you try to look the heart lah. Try to look for any murmurs by doing the maneuver lah. But try not to do immediately like that, and then straight away go to lung lah. I know. This is like a virtual practice. You do that routinely. It's just to train the learning, the thinking process instead of assessing you in terms of the proper examination. But bear in mind that in real exam, you need to give good amount of time. Okay, you need to give like 3 to 4 minutes to examine properly. Take your time. You will examine the leg as well, and then once you're okay, and then only then you ask back the question. Sometimes you can also ask the question while you examine the patient. Okay, those questions that not so important you want to ask, you can do that. Like for example, the social history. Then you want to focus, you can multitask a bit. You want to do when you examine the peripheral, you can do that. Just like chatting with the patient and then examine. You don't have to say out your finding also. Also, that will save your time. If let's say you think the scenario is a bit complex, you need to really ask a lot of questions. You want to examine the patient early, and then you're quite sure diagnosis, you can do that. Okay. And then the judgment is good. I would say okay, can get full marks. Concern is fine. Physical sign, generally this is a normal cardiovascular station. If you mention anything abnormal, then we'll be penalized. Okay. So some of the surrogate, some of the station for consult can be a normal finding. Okay. So you should not, but you should mention all the negative, important, relevant finding. Like for example, the vital signs from the outside, it seems that he's stable. And then if you mention that examination, do not notice any murmurs or any evidence of heart failure. Okay. And then you can do essentially it's a normal cardiovascular finding. Okay. And then your differential diagnosis, yes, you mentioned all that, but you didn't. You mentioned a pulmonary infarct and PE. PE is a good differential because I offer the history of traveling, but you did not mention about anything about the heart other than ACS. What can be due to chest pain? Cardiac cause of chest pain other than ACS is what?
Myocarditis, pericarditis.
Yeah, pericarditis, myocarditis, endocarditis. Okay, so this is also important to be mentioned. But yes, you know that no fever and no got a bit of traveling history, but no flu-like symptom, no fever or cough, and then and also the important point that you manage to elicit is actually no prolonged fever lah. But at the same time, also need to make sure that any patient with intermittent chest pain, you need to make sure this is not the heart before the lung. Okay, and then the welfare I think is good. So to recap, I think most of the finding you got it, but when you mention about the concern, right, you should mention immediately when the patient told you that he smoked 1 pack per day, right? Because you will forget if you don't mention that. So usually the usual practice is we ask them to stop smoking. Usually, if you are keen, we can refer you to smoking cessation clinic for further information. Are you okay? So you should mention about that. I will advise you against smoking. If the patient is alcoholic, but the unit is actually less than 12 units per week, then it's fine. But more than that, you should also advise to cut down their intake. And in those related scenario, like alcohol related scenario, like liver disease or like for example, scenario of tremor, you may want to assess the CVAS score by asking the patient to is that the first thing, the eye opener, the cut down, the withdrawal, the irritation, the annoyed part. So you can do that, but generally, if let's say just same goes to smoking, you cannot just stop at you're active smoker or 1 pack per day for 10 years. Just like that. You need to advise the patient to stop smoking. Okay, because this is like a safety net. The safety net is that if you don't mention that, then and in under your concern or management, you did not mention for patient to stop smoking, then you basically did not address that lah. Okay, so it's not good. So that's the reason why people likes to mention it immediately, like during the history taking station under the social part. If patient is a smoker, then you should really tell the patient to stop smoking and refer. But you want to do it later, can, but to me it's a bit risky because sometimes you may forget when as a lot of things come by. And the management, yes, to stop cocaine, stop smoking. And intermittent coronary vasospasm, you can consider use of sublingual GTN if needed, but generally there is no role of giving antiplatelet. You can also give options like calcium channel blocker, diltiazem, to actually reduce the vasospasm incident. Let's say it's still occurring, but generally they are self-limiting. And then the main focus is again the ASCVD prevention. It's not to start patient on antiplatelet, okay? Lifestyle modification, diet, rate reduction, exercise, okay? So that is it. So the cardiac, the approach to chest pain, I think your approach is quite okay. You know what to ask. You divide your chest pain to cardiac, pulmonary, and also some reflux. You can see that the abdomen symptom you did manage to screen through. And then, so that would be great. And then another thing important is that if you're encountering like Marfan syndrome or even like elderly patient, you want to make sure you're not dealing with chest pain that radiate to the back. So that's why it's important for you to ask about specifically for any radiation to the back, because that may suggest aortic dissection. And the clue to aortic dissection is perhaps when you have to ask for 4 limbs BP, the differential BP. The patient will have differential blood pressure and also the pulse. So this is the thing that you may miss if you don't do as a part of routine for chest pain approach. But generally in this scenario, I wouldn't be so concerned because I know that there's not much of pain radiation to the back. It's like more like ACS kind of true cardiac chest pain. So you want to proceed further? Yes. Okay. So sometimes a scenario of chest pain can also lead to pulmonary embolism, and you need to know, it's not enough to know the diagnosis of pulmonary embolism. You need to know what is the cause. Like again, back to the question of we discuss a scenario of thrombosis. You need to elicit that whether this is congenital or acquired. Congenital can be congenital thrombophilic disorder, thrombophilia, or can be like acquired like APLS, the nephrotic syndrome, inflammatory bowel disease, PNH, and all the myeloproliferative neoplasm that we mentioned, okay, or even any form of malignancy. But identifying the cause is also not enough. You need to know any ongoing or active precipitating factor that for this patient is actually traveling, the air freight travel. For the case just now is actually the OCP use. So you also want to ask about surgery. Yes, you ask about that as well. And then any immobilization as well. So that is important. And let's say this is PE, you also need to ask any pain over your calf, any swelling over your calf to suggest any predisposing DVT to begin with. Okay. And then it's also not enough just by going this through. You also need to assess the complication. So subsequently, you ask whether patient have any breathless, and whether patient you have to check the SpO2 at the outside scenario if it's given to actually see that whether patient is hypoxic or not, and then whether you need to admit the patient or not. Hemodynamic is how that will affect on your management. And sometimes not common. Let's say it's a chronic chest pain, and let's say patient may have some, for example, some interstitial lung disease or some bronchiectasis, and then you ask, it doesn't seem like a respiratory or lung related chest pain. Oh, sorry, it does seem a respiratory chest pain in which it can be like periodic in nature, for example, and then but when you explore further, you don't really find any obvious clue, because acute exacerbation of this lung problem shouldn't usually cause chest pain unless it's hypoxic. So you may also want to think of the possibility of chronic thromboembolic with pulmonary hypertension, CTPH, CTEPH we call it. CTEPH can happen in those with chronic pulmonary disorder that develop severe pulmonary hypertension, and that pulmonary hypertension predisposed to stasis and clot formation, causing a chronic PE in a way. So that is also another possibility, but it's not very common to come out in exam. But you should suspect that if it's something more chronic and with underlying lung disorders. Other than that, I think the approach to chest pain is just the what we usually do. Same like medical student, the diagnosis not much. It's just we need to know. Another thing is chest pain, whether or not you need to ask got fever or not. Because chest pain with fever can mean a few things. Chest pain with fever can mean, usually it means the heart problem, okay? It means the heart, whether it can be pericarditis, myocarditis, or infective endocarditis. The important thing you want to exclude is the infective endocarditis and try to elicit the risk factor. Myocarditis usually is a viral or it's an infection. You need to elicit whether patient is unwell or any flu-like symptom in the past, okay? And if let's say you're dealing with pericarditis, then yes, it can be pericarditis from, for example, patient is a renal transplant patient, and then develop this pericarditis kind of chest pain, cardiac chest pain which actually have fever. Then you suspect pericarditis. It can be due to, for example, things like CMV pericarditis, because of immunosuppression state, or can also like RVD also can also explain to that. And then don't forget that in exam is quite common. Patient post angio, post cardiac intervention, post pacemaker or whatever post cardiac implantation device, or even angiogram alone, patient or even some closure device like septal ASD closure or whatever intervention device procedure, patient may predispose to Dressler syndrome. Right? Dressler syndrome is not entirely due to procedure itself, but it's actually due to some form of antibody process. It's autoimmune process. There's this anti-pericardial antibodies that can be detected. Okay, so Dressler syndrome can come on the exam as well, particularly in those patients with previous cardiac procedures. So, and they usually can have intermittent chest pain. They usually can be breathless as well because that can actually build up the pericardial effusion. And if it's severe enough, it can even cause tamponade. Generally, they respond by NSAID. They don't respond really by antiplatelet or any, for example, like pericardial tapping. Pericardial tapping or pericardial synthesis only important in those like cardiac tamponade. So this is also another important, less common chest pain scenario that can come up. So we will proceed to the next scenario. As the last scenario. So last one, I actually cannot remember who. Okay, Aaron. Aaron, are you there?
Yep, doctor.
Yeah, okay. So you are ready, yeah? We will give you 4 minutes and then when the time's up, I will let you know.
All right, thanks.
Okay, so we will start the counter. Okay, time's up. This is the patient, Mr. Jackson. Dr. Aaron, you can start now.
Hi, good morning, Mr. Jackson. Can I confirm that you're 40 years old?
Yeah, I'm Jackson. I'm
My
40.
name is Dr. Aaron, and I'm the doctor in the medical outpatient clinic today. And
Mhm.
I've been hearing that you have some fever for 3 months. Can you tell me more about this?
Yeah, doctor. I've noticed that I have fever for almost 3 months and usually occur in the middle of the night. I, I realize that in the morning I seldom feel any sensation of fever, but it's usually towards the night I feel quite bad, and sometimes it can also associate with a lot of shivering and also uh, chills.
All right, I'm sorry to hear that. I hope we can get to the bottom of this. Has it been gradually getting worse or more frequent, the fevers?
I would say it has been persistent, but it did not get worse.
Okay. And do you notice any other symptoms besides the shivering together with the fevers?
I also noticed that I have sweating at night as well until I have to change my clothes every time I wake up in the morning.
Okay. And how is your whole bed wet as well?
Um, Generally my bed I'm not sure because when I wake up it's already dry, but my whole shirt will be wet. My
Okay.
pants also.
Have you tried anything to relieve the fevers? Does anything help?
Yeah. If I try to take more paracetamol, it tends to reduce, but if I don't take, it will come again.
Okay. And have you checked your fevers at home? How high does it usually go?
Yeah, I don't do that at home, but I have visited a few doctors in GPs. Usually when they check my body temperature is about 38.5, sometimes even up to 39.
Okay. And do you have any joint aches or muscle aches?
No,
Okay. And do you have any cough?
no,
Okay. And do you have any difficulty in breathing?
no,
Any noisy breathing?
no,
Do you experience any pain anywhere in your body while you have this fever?
no,
Any headache?
no,
Okay. And any pain in your chest?
no,
Any dizziness?
no.
Any feeling like your heart is beating out of your chest?
No racing or heartbeat.
Okay. And any changes in your bowel habits? Do you have any diarrhea or any loose stool or constipation?
No,
Okay. Any changes in the color of your stool?
no. It has been the same.
Okay. And do you experience that you've been losing weight or any changes in your weight?
Yeah, I've lost quite a lot of weight. I think I lost about 6 kilos in the past 3 months.
Oh dear, that's really concerning. And what about your appetite?
Yeah, my appetite is generally reduced.
Okay. Do you feel like you want to throw up?
No,
Okay. And have you vomited in these last 3 months?
not really.
Okay. And do you have any flu-like symptoms or any common cold symptoms like runny nose,
No,
any sore throat,
no,
any problems with your waterworks? When peeing, do you notice any changes in the color of your urine?
no.
Any pain in your tummy?
Tummy pain? No,
Okay. And do you have noticed any rashes,
no.
any spots or any pigmentations?
Not really.
Not really. Okay. All right. Um, and do you notice that you're passing out more urine than usual?
No,
Okay. Do you notice any sores in your mouth?
no,
Do you notice any excessive hair loss?
no,
Any tightening around the fingers or the mouth?
no,
Any red eyes?
no,
Okay. And do you notice any hand tremors?
no,
Any preference to hot or cold weather?
no.
Okay. All right. Any sick contact? Anyone is sick that you come into contact recently?
Not that I know of.
In the past 3 months, no.
No.
Any recent traveling overseas or going to the outdoors, for example, to the jungle or the river?
No.
Okay, all right. Besides that, do you feel any lumps or bumps in your body?
I'm not very sure, but I do feel that my left neck, especially towards the left side, it feels some small lump there. Previously, I
And
did not notice that.
I see. When have you noticed this?
I think just 2 weeks ago, I started to realize it.
Okay, all right. And has it gradually gotten bigger?
I would say it should be because previously I did not realize that it's this mass before.
Okay, all right. And just to ask, do you have any past medical history that I should be aware of?
Yeah, I got diabetes and also hypertension.
I see. And how is the control of your diabetes?
The doctor told me it's good. We just taking metformin, two tablets per day, and then the sugar, the doctor told me actually is about 5.6% for 3 months
Oh,
sugar control.
that's good. And besides diabetes and hypertension, have you been hospitalized before?
No,
And have you undergone any surgeries before?
no.
Okay. In these past 3 months for the fever, have you visited any GPs to take any medications?
Yeah. Like I said just now, I have tried to visit many GPs. They give me generally just paracetamol to reduce the fever, but it comes and goes. So I really feel that they are not helpful. I don't know what happened.
I see. And do you take any other drugs besides metformin?
And also the amlodipine for the high blood pressure, only 5 mg once a day.
All right. Any recent changes in the doses of your medication?
No.
Okay. Are you allergic to any medication at all?
No.
Do you take any traditional medication or any supplements?
Oh, no.
Okay. And a question we ask every patient, have you ever smoked?
No.
And do you consume alcohol?
No.
And in your family, is there any illness that runs in your family? Like
My
any
father and
diabetes,
mother have diabetes as well as high blood pressure as well.
any cancers that run in your family?
No, not that we aware.
Okay. And a question we ask every patient as well, have you used any illicit drugs before?
No.
Okay. And what do you work as, Mr.
I work
Jackson?
as a promoter, a sales promoter.
Okay. And how has this been affecting you?
Yeah, because of this fever, I feel sometimes when the fever gets very high, I can see that my whole body actually is weak, and this is actually affecting my work. Cannot really work well because of this.
I see. I hope that we can get to the bottom of this. Can I quickly examine you?
Yeah, sure.
Okay. So I'm just gonna look at the patient's general build. Is he cachextic?
He is thin, but not to say very caucasic, not much of wasting.
Okay. And looking at the hands, is there any signs of clubbing?
No.
And any signs of pallor in the palmar
Yeah,
crease?
there is a conjunctival and palmar crease pallor.
Okay. And checking the pulse, is it regular and heart rate is 70 beats as outside?
Yeah. Heart rate is the same, and the pulse volume seems regular. Seems good.
Okay. All right. Noticing any rashes around the arms or the trunk?
No.
Okay. And checking in the mouth for any oral sores?
No.
Looking at the neck, observing for the lump, is it an irregular lump only on the left side?
So when you examine the patient neck, you notice that there is a palpable lymph node over the left cervical region. It actually measures about 2 x 3 centimeter. When you feel it, you feel firm, and then non-tender. It's quite the consistency is firm and it's not mobile.
Okay, just checking for the whole cervical area for any other lymph nodes as well.
The rest of it is negative.
Asking the patient to swallow so that to make sure it's not the thyroid.
Yeah, there's no obvious mass or swelling that actually move with swallowing.
Okay, checking the axilla also to feel for any lymph nodes bilaterally,
There's no axillary lymph node palpable.
and also inguinal as well.
Inguinal, there's also no.
Okay. Can I know the left neck is the location of the lymph node? Is it supraclavicular or
Yeah, it's a supraclavicular.
supraclavicular? Okay. And next I would like to lie the patient down to palpate for the abdomen.
Okay. As you lie the
With-
patient down,
Mhm.
yeah, the abdomen finding is the abdomen is soft. There's no tenderness. However, you realize that uh, there is no hepatomegaly feel. However, there is a moderate amount of splenomegaly. You can feel the splenic notch at the junction of the paraumbilical region.
Mhm. Okay. And just asking back the patient, do you feel any feeling of fullness recently when you eat?
Yeah, sometimes I do feel a bit full, easily fullness when I eat something because of discomfort over my tummy.
I see. Okay. And also to ballot the kidney to make sure there's no ballotable kidney.
Kidney is not ballotable.
Okay. I would like to listen for the lung bases to check for any cracks,
Okay, there's no crepitation.
and listen to the CVS to listen for any murmur.
Okay, there's no murmur heard.
Okay. At the epigastric region, there is also no mass palpable, right?
No,
Okay. Check for any pedal edema.
there's no PD edema.
Okay. All right. So Mr. Jackson, can I ask what is your concern?
Yeah, doctor, I'm very worried. What do I have?
After taking a history and examining you, I'm quite worried about what you have told me. So with all your symptoms, together with the loss of weight and the fever and the sweating, I'm actually considering actually a diagnosis of a type of cancer that is in the lymph node, which is called lymphoma.
Oh, okay. So what is the next step for me, doctor?
So right now we will need to admit you to the ward for extensive workup. So this would include taking your bloods as well as arranging a biopsy of
2 minutes left.
neck swelling that you have told me, and also do some scans, which includes a CT scans of your might be of your whole body.
Oh, doctor, if I refuse admission, is it possible to work out as an outpatient? I just see you in clinic.
Mm, it would be preferable for us to take some bloods today just to make sure all the bloods are okay. If the bloods are okay, we would be able to arrange for outpatient. But however, currently you are having active fever, so 38.5. So we would still advise you actually to admit, but we will definitely respect your decision.
Okay, doctor, I actually have a girlfriend now, and actually I'm planning for my marriage. And then I also plan to have kids after my marriage. Will there be any issue at all?
I see. So yes, there will be some issue in the sense that if we arrange for all the workup and confirm the diagnosis of lymphoma, unfortunately, there are some medications that we might start that might affect fertility. So do not worry, we will have other ways of collecting, for example, sperm preservation, so that and the sperm bank to make sure that your fertility is can be preserved for the future for having kids.
Oh, okay. Is there any other possibility other than lymphoma, doctor? The diagnosis seems very scary.
Yeah, so actually having long fevers, it can be due to other infections as well, and also but because of all your symptoms, it can be due to other forms of cancer as well, because you have quite a significant weight loss. So I would think that lymphoma is my first diagnosis. However, other
Okay,
forms of
time up.
cancers we have to rule
Okay,
out.
Dr. Aaron, would you mind to go through list of your differentials and then tell me your most likely diagnosis?
Okay. I've taken history from Mr. Jackson, who presented with 3 months of fever, as well as loss of weight of 6 kilo in 3 months, and noted left neck swelling for 2 weeks that's gradually increasing in size, with night sweats and shivering. And upon examination, there is a splenomegaly as well as a left supraclavicular lymph node. So my primary diagnosis for this case will be a lymphoma. However, I need to exclude other malignancies with a supraclavicular lymph node, particularly the malignancy of the GI tract, so can be a gastric cancer or a pancreatic cancer, and also I
Okay.
have to rule out
Any other
chronic
differential?
infection. Other differentials with night sweats and chronic fever can be malaria as well, but he doesn't have any traveling history to the jungle.
Okay, any other differential?
Tuberculosis can be a differential also, but he does not have any respiratory symptoms. However, he does have a lymph node that can present this way also.
Is there any other differential?
Not too sure.
Okay, never mind. How will you investigate this patient?
So I would like to send off FBC, RP, and also liver function tests, and also calcium and other electrolytes such as magnesium and phosphate, LDH to send, and uric acid to send for the tumor lysis workup. And I'll send a full blood picture to look for any abnormalities like leukoerythroblastic picture. I'll arrange for excisional biopsy of the lymph nodes, and also I would like to send for viral screening, and also send for tumor markers as well, such as AFP, CEA, and CA19-9. And also I would like to do a chest X-ray as well as a CECT of the thorax, abdomen, and pelvis.
Excluding the neck.
With the neck, neck, thorax,
Okay.
abdomen,
Okay.
and pelvis.
All right. Any other investigation?
Um, mm,
Do you want to consider working on the infections or thinking along the line of other possibility?
Also CRP and ESR as well and also send for sputum AFB and also sputum MTB-CNS as well.
Okay.
And
And
also
what
do
is
a
the
lung
rationale of sending the viral screening you have mentioned just now?
rationale of sending.
The viral screening, the infective screening.
So prior to starting for any chemotherapy before chemotherapy.
Okay. All right. Then if you're thinking along the line of management to start chemotherapy, then what is your other important things to assess other than infective screening?
I would like to, because the patient is keen for fertility, so I would like to refer to the ONG.
Okay, that one is
ONG
management, right? That one is management. But how about the investigation, the pre-chemo assessment? Anything else to be done?
pre-chemo assessment, viral screening.
Okay, never mind. How will you manage this patient?
So I would like to firstly admit this patient to the ward because he's having fevers. If he's having active infection, to treat the infection. And after the diagnosis is confirmed, after biopsy, I would like to I would like to refer him to a hematologist unit for consideration of starting of chemotherapy. And depending on the type of the lymphoma, also
Okay.
like to refer to the ONG doctors for the sperm preservation.
Okay, good. Hands up. It's good. Yeah. Are you okay at the background?
Oh, I'm so sorry, got some background noises.
Okay. So, how would you feel about this scenario?
I'm not 100% sure of my diagnosis because I feel like it can be lymphoma or other kinds
Or
of
what?
malignancy. I feel like might be other kinds of malignancy, but not
Mhm.
very sure.
Okay, so my few comments on you. I think everyone will agree that your history and the way you ask and the way you answer is quite smooth. You are very fluent. That's a very good thing. And you have a good background knowledge as well on the common things as well. You think about thermolysis workup. You think about along the line of fertility preservation after the patient asks you. Yeah, I think you're very matured in terms of this thinking process. But there's a few things that I'm not happy, okay? Because you are good, so you should not be good, you should be better, okay? So first thing is actually when you encounter any scenario of prolonged fever, right? You cannot and never, and you remember this because I'm going to mention again and again, you should not and should never forget to ask about, should never forget to ask about unsafe intimate relationship. You did not ask that. This is very important. And the other high-risk behavior also did not explore whether patient got any recent or in the past got any blood transfusion, patient got any needling or tattooing, got any use of illicit. You did ask about illicit drug, but you need to ask in particular got any use of injectable drugs or any sharing of needles, and whether there's any tattooing, ear piercing, and then whether there's any unsafe intimate relationship. This is like a confirmed thing you need to ask. You cannot afford to miss this because the last thing you want is to miss a diagnosis of RVD. Okay?
Yeah.
So that's a very important thing because this can be RVD, this can be RVD with opportunistic infection, can be lung, can be abdomen, can be a lot of various type of variable symptoms. But that's why it's important. You cannot afford to miss that. And when you think about lymphoma, TB, you cannot also miss about RVD because RVD can also lead to lymphoma. Oh, patient can have a secondary lymphoma from the RVD. RVD itself can cause lymphoma or even can be due to disease like CMV or EBV. Those can actually predispose the patient to get lymphoma as well. So it's important. That's why when the examiner asks you, when in the exam, when you give like 2 or 3 differential diagnoses, but if examiner still asks you, what is the other differential? You know that you must tell yourself that you're not hitting the answer the examiner want. Okay? Or maybe not the primary answer, like maybe not the primary diagnosis, but at least in their differential diagnosis that they have calibrated. So you must know that certain things cannot be missed. And in this particular scenario of prolonged fever, you cannot and should never miss a history of high risk behavior. Okay, so this is my first point to you. Second point is that I don't know whether because I feel that you are quite reluctant to say infective endocarditis. Although I know that you try to screen for all the heart symptoms and then fever, heart symptoms, you did to screen them, and then in your cardiovascular examination, you did particularly mention whether there's any murmur. It seems like you know that you are going towards to screen for IE, but IE should always be a differential diagnosis in a prolonged fever because the diagnosis is actually not very clear-cut at times, not fulfilling all the major criteria, right? We know about the Duke's criteria. So
Yeah.
not just fever, okay? And then you need an echo, you need a culture positive. How we get that from the history and the scenario like this? Or we cannot even get an ECG or prolonged PR interval. So you ask about thromboembolic or immunologic phenomena or even vascular phenomena, you try to elicit for that. So you should also mention the negative point that there's no signs of infective endocarditis like blood spot perhaps no lah, Janeway Leeson or Slurlot. And then you should also, in this kind of scenario, you should also offer to do a fundoscopy as well to check for whether there's any evidence of raw spot. Okay, so all this, although I know that you are quite sure that your direction is towards lymphoma, but again, the purpose for you to examine the patient and the history is to get the negative findings to exclude your differential. So bear in mind, we also need to do that as well. You need to mention about that to show that you're thinking towards the line of all those possible differential diagnoses. And then the autoimmune screening symptom-wise, I think you asked a few. I can see that. I know that you try to rule out some autoimmune disease to may suggest prolonged fever. It's also good that you ask about thyroid symptom. You ask about hand tremor. You ask about weather preferences in terms of hot or cold weather. You ask about weight loss or weight change. Definitely you ask. So all those, I know that you want to try to rule out whether patient has any thyrotoxicosis. That's good from the history. Okay. So, but it's not good enough if you miss the RVD and you miss the high risk behavior. Okay, that's the most important point. And then my question to you is that do you need to do bone marrow aspiration and purifying in the suspected diagnosis of lymphoma? Not easy to answer. But yes.
Not. I think I remember not necessarily. I remember. It depends on the N-abo staging. I'm not very sure. I can't remember.
N-abo staging only tells you the degree of involvement. Okay, so a stage 4 or stage 3, regardless of which one, doesn't necessarily mean the pro-prognosis because it depends on the types of lymphoma. Okay, so N-abo is just 1, 2, 3, 4, depending on whether single lymph node, regional lymph node, ipsilateral or both sides, and then or whether it's extend beyond the pleural. So that will be 1, 2, 3, 4. And A and B is just whether got B symptom or no B symptom, right? But it does not
Is it
tell
cell
you.
count?
Sorry, what? The cell
Is
for
it
the
because
counts.
the cell counts? If the
Not
cell
really.
counts suggest bone marrow infiltration, then we need to do BMAT.
Yeah. Yep, that can be a clue, but not a good answer, not the best answer, I would say. So a common question that all of us face in a clinical situation varies between institution to institution, but the general idea is the same. So let's say you are dealing with a case of lymphoma, whether you should go for marrow or not. Actually, the answer is a yes and no. So you need to know what types of lymphoma. So lymphoma, if you want to you can classify it by non-Hodgkin or Hodgkin lymphoma, right? But the more practical way to classify lymphoma is whether you are dealing with aggressive lymphoma or you are dealing with indolent lymphoma. Indolent lymphoma is like slow-growing lymphoma. Aggressive lymphoma is like what? It's like Hodgkin lymphoma. It's like Burkitt lymphoma. These two are very aggressive. In fact, Burkitt is more aggressive than Hodgkin. And then perhaps the second or the third aggressive one is also the diffuse large B-cell lymphoma, DLBCL, which is the commonest non-Hodgkin lymphoma. So these three are the very aggressive lymphoma. Okay, no doubt this three is aggressive lymphoma. And what are the other possibility? The other possibility is that some other lymphoma, which is like peripheral lymphoma, all those are not very common. And then indolent lymphoma is those that slow going. So what are the slow going lymphoma that you know? It can be mantle cell lymphoma. It can be some other lymphoma like hairy cell. Hairy cell is leukemia. Lymphoma can be mantle cell. It can be some other variant like lymphoplasmacytoid or all those rarer form of slow going kind of lymphoma. Okay, peripheral T cell or also possible. Marginal zone is also one of it. So when do you need to do bone marrow? So the idea is you should do a bone marrow in all suspected case of lymphoma, especially the aggressive lymphoma. Okay, you must do the bone marrow. Okay, if there's a confirmed diagnosis of HBE confirmation of lymphoma, you should do the bone marrow. But the caveat is that if let's say you got PET-CT facility while doing a staging, let's say patient do a PET-CT staging, then yes, you may not necessarily need to do. You can actually omit the bone marrow and aspiration to find for that reason, because PET-CT is the only scan that can see the marrow involvement. Ultimately, you want to know the reason of doing BMAT is to know whether the lymphoma got any infiltration to the marrow, right? That's the most important thing. And if you do PET-CT, you already do that, so you doesn't need a BMAT anymore. Okay, so I hope everyone clear on that. And then what kind of lymphoma that you really need to do a BMAT? Okay, so those patient those patients, for example, I mentioned that Hodgkin lymphoma, Burkitt lymphoma, DLBCL, and there's some T-cell lymphoma like anaplastic or peripheral. Those are the one must do. And then, but at the same time, those slow-going indolent lymphoma, we also need to do a BMAT as well. We cannot omit the BMAT unless the only caveat is unless you have a facility to do PET-CT before you start chemo, then yes, you may not need to do. Why does it matter if it involves the marrow? So the treatment matters. First, let's say usually lymphoma, if it's aggressive lymphoma, meaning to say it extends beyond the lymph node, the regional lymph node, or the contralateral lymph nodes, it extend like we are talking about Ann Arbor 3 or 4. So if it extend beyond, then the chemo regime matters because we need to add on the intrathecal methotrexate. Okay, that's the main important difference because we need to add on with that therapy. Another thing is that the chemotherapy is also matter whether you want to give R-CHOP, you want to give R-EPOC, or you want to give like RCVP. Okay, RCVD is mainly for Hodgkin lymphoma, and then non-Hodgkin is usually R-CHOP or R-EPOC. And also depends on whether you want to chop the patient without the R. So all this does not need to be mentioned in the discussion for MRCP, I feel. But it's generally you need to know the rough management so that you know what you are talking about. We're talking about whether this is aggressive disease, so whether or not the management is what. Chemo, you can just mention about there's few types of chemo. I will refer to the hematology team to decide. Yes, correct. That is the correct answer. You doesn't need to know in detail, but it's good for you to at least know a rough idea of what is the types of chemo that usually people offer, and then what are the things that you do. So usually, I mean, just a like general idea. Usually for lymphoma, after the chemo, usually how many cycle of chemo? Usually ideally should have a staging CT or PET-CT before chemo, and then usually after 3 cycles of chemo should have an interim PET-CT scan, and then to assess the response. If okay, then you proceed with another 3 cycle, and then after that end of therapy meaning to say complete 6 cycle of the chemo. Okay, so end of therapy you repeat another PET-CT as well. So let's say patient did 6 cycle of chemo, interim PET-CT is responded, the lesion smaller, and then after end of therapy, we call EOT PET-CT, in which fully resolved, the lymph node all resolved, then this is what we call as clinical remission, CR, right? But let's say it's not fully resolved, it's still like become smaller, but still there, then this one is already considered refractory already, okay? Refractory. And if the patient is not really responded well to treatment, then it's considered relapsed refractory already. And relapsed refractory, those you need to go for conventional chemo, which is more toxic, okay? Can be ice, can be rice, can be a lot of things, but it's not the main point of discussion. The main point of discussion for you is, I think in your communication skill is good, you talk very soft, and then you're very fluent, and then you did not use any jargon, that's very good. But again, I think you also use waterworks, like I think all the other candidates just now also use the words waterworks. I generally discourage everyone to use waterworks or back passage for the passing of motion or passing of urine because it's like very ancient and very classic English that we doesn't even use that in our daily routine practice, right? So my idea is that I would prefer everyone to use like how is your bowel motion, and how is any issue in passing urine. So I will usually mention about that. Okay. So another thing is your examination is good, and then your judgment is good, I would say. Concern is okay, physical sign is okay. Differential diagnosis, unfortunately, I cannot give you full marks. And your judgment wise, I would say is okay. But your history, some examiner, if you don't ask about the RBD, right, the history, they will go borderline. They won't give you full marks because it's a very important, very, very important differential to exclude. Okay.
Yep.
So this is the marking scheme, just something to go through. I think you got most of it in terms of the history. Examination is also okay. And then generally the differential diagnosis, you have mentioned malignancy other than lymphoproliferative disorder. That can also include the GI malignancy because it can also mean it's a sign of positive Trousseau sign, right? If it's like a left supraclavicular lymph node. And then yes, IE is something we must mention, RVD as well. And then autoimmune is also, we just put it as a differential because you say you excluded, although it's less likely down the list. Okay. And then the answer that I want you just now to mention is the echo and the ECG cardiac assessment. You cannot afford to miss the cardiac assessment. Okay. Viral screening or infective screening you mentioned is before chemo. You want to make sure patient does not have positive screening. But do you know the exact reason why? Actually, we only look at one thing, basically.
So the Hep B need to start the antiviral for Hep B. For
Whether
rituximab.
the patient core antibody is positive or not. Because with patient core antibody is positive, even though HBsAg is negative, patient might have a occult Hep B infection. Okay. So because there's three possible reasons to this kind of finding, right? In which HBsAg, the antigen S antigen is negative, but the core antibody is positive. There's three possibilities. First is you are dealing with occult Hep B infection. Second and third reason, do you know why?
Not sure.
Not sure, right? Or it can actually at the level of seroconversion, in which at the point of time the S antigen is already seroconverted, but the S antibody is still not detected yet. And then at the same time the patient may not have any I mean it's within the seroconversion period. Or the possibility is after patient recovered for hepatitis B infection, and then the antibodies actually wear off, in which you would expect the anti-HBs to be positive, but because the wearing off phenomenon of the S antibody, so that antibody is negative. So you get HBsAg negative, anti-HBs negative, but your core is positive. Okay. It can mean the past infection. And how you differentiate all this is to proceed with HBV DNA test. If the HBV DNA is positive, regardless of title, in a patient that immunely suppressed, like RVD or even any patient on high dose immunosuppression, this kind of patient should be treated. That's why you need to treat if let's say it's positive. Another thing is about the virus screening is also you want to make sure you do not miss a RVD, because RVD can also cause lymphoma, like what you mentioned, right? So it's very important for us to take a virus screening before the chemo, before the therapy. And then another thing is the ECG and echo. Don't forget about that. We must make sure the patient is good. So when we talk about cancer treatment, we need to know the patient performance status, the ECOG. From the history, you roughly know that patient looks good, can take care of him or herself. The next thing is actually look at the Towson pre-morbidity index. I mean, we don't need to mention that in the exam, but generally it gives us assessment that whether patient got a lot of comorbid or not. Because a lot of comorbid, we know that patient outcome may not be good. Like this patient well controlled, everything looks good. Okay. So another thing is also need to know the heart status. So that's why part of investigation you should also include about the ECG and the echo. Okay. And then the tuberculosis workup part you have mentioned. This kind of scenario I will mention to culture the patient. Okay. And I will also take 3 sets of culture because I really need to exclude infected endocarditis. If I want to exclude my differential diagnosis, i.e., then 1 set of culture is not enough. I need 3 sets of culture at a different site and timing. Okay, so I think that will be the discussion for this station. Anyone have any question? I think tonight I choose to focus just on four consultation scenario instead of previously I tend to go like 5 or 6, because I start to realize that perhaps is to focus on the quality of the discussion is also matters on how to approach as well. So I think Aaron have a good approach. Perhaps Aaron have encountered a similar case or even learn from previous scenario before. So generally this is how we approach to differential diagnosis of the prolonged fever. Okay, you need to divide yourself in the back of your mind whether you're dealing with infectious, autoimmune, cancer, or like others. Okay, because we need to exclude one by one. I can see that Aaron also think about malaria, which is not surprisingly. If you go by this list, you should go by one by one. What are the common infection we associated with so-called PUO? The old name is called PUO. Now we don't label patient as PUO. Okay, but we will just put as undifferentiated fever, prolonged undifferentiated fever. So it can be IE, can be TB, brucellosis, melioidosis. So occupation matters is important. These are the common one. Then you go by bacteria, parasitic, and virus. So you go by all that. And then autoimmune can be the common one is actually the SLE, sarcoidosis, and the adult onset still's disease is also important. Okay, how we need to exclude that is, I can see Aaron is, I think he asked me rash about 3 times, if I'm not wrong. He asked me a lot of time for the rash. Yeah, so I know that he tried to exclude that because he asked me about rash, fever, rash, joint pain, rash again. I was like, okay, this one maybe is thinking about adult onset still's disease. Maybe the first rash is actually thinking about SLE. Second rash is thinking about sarcoidosis. And the third one maybe is like ASOD or something. But you know that adult onset still's disease have their own diagnostic criteria. It is generally a diagnosis exclusion. But having said that, we also need to know about Yamaguchi criteria to diagnose about the 4 major and also the 6 minor. Okay, so vasculitis also possible, and then the infection trigger like reactive arthritis is also possible. So it also need to know whether the patient have any predisposition or any recent infection. Neoplastic commonest is the myeloproliferative or lymphoproliferative disorder, and then non-hematological is like solid organ or even paraneoplastic. Paraneoplastic can also be one of the manifestations sometimes. And then drugs can be, if patients have multiple antibiotics, you may need to suspect drug-associated fever. Can be common in those like very anxious patient taking multiple antibiotics. The fever is like getting worse. This is a clue that you are dealing with. Maybe it's antibiotic fever. Okay, and sympathomimetic agents like, for example, cocaine, stimulants, all those, for example, amphetamine user, that can also predispose to prolonged intermittent fever. And then metabolic is the one that we mentioned just now, in which Dr. Aaron, remember, is the thyrotoxicosis. Okay, Aaron, you got any question?
No. Thank you so much, Doctor.
Yeah, thank you. So everyone, okay, if anyone have any question, then we will can post in the group later on, or else I will end the session.